respected Dr. Ashish Kumar Jha, IJNS Patna, Senior Gastroenterologist.
Thank you, Chairperson, and thank you, organizing committee, Professor Neil, for giving me opportunity. In this two case capsule, one I will discuss regarding the complication, another thing is a observation. So case 1, lumen opposing metal stent misdeployment during EVAS WOPN drainage, endoscopy rescue. Pancreatic necrosis is associated with high mortality and morbidity. A step-up approach with endoscopic drainage, laparoscopy, hyperperitoneal drainage, and minimally invasive surgery have recently replaced the open surgery, attaining with mortality. Case history: a 30-year-old female diagnosed to have acute biliary pancreatitis with acute necrotic collection. At 4 weeks, the patient continued to have abdominal pain, vomiting, dyspnea, and fever. Therefore, she was referred to us. Examination revealed pallor, abdominal lump, and bilateral pleural effusion. Blood investigation showed hypoxemia, anemia, neutrophilic lymphocytosis, hypokalemia, mild liver concentration, and elevated CRP and procalcitonin. Chest X-ray showed a bilateral effusion, and the CT scan showed a large peripancreatic walled up pancreatic necrosis. So patient was treated with a conservative therapy, including oxygen supplementation, non-circulation, IV fluids, broad-spectrum antibiotics, blood transfusion, and potassium supplementation. Pleural tap by blood, and patient was stabilized. The patient diagnosed to have infected WOPN, walled up pancreatic necrosis. US guided cystostostomy using LAMS was planned. So here we can see in this video, once we focus the WOPN, and at least 50% of necrotic debris was present in this WOPN, and then we just measured the distance between stomach cavity and cyst cavity. It was less than 1 centimeter. So we decided to puncture, and we punctured with a 19 gauge acquired needle. And fluid aspiration was done to confirm exact position of needle. And then 0.035 exchange wire was placed through the 19 gauge needle. And then with the cystotome, we tried to dilate it. 10 pen gauge cystotome was used, and followed by CRE dilatation, 10 mm CRE balloon dilatation was done. So then we intended to deploy a lumen opposing stent. So stent was a J-Mitra made in India and was intended to deploy, but because of gushing of pus and poor visualization, or because of pouring of pus, the marker of LAMS was not properly identified, and therefore LAMS was misdeployed inside the WPN. This is the site. So what was the possible reason for misdeployment in experience of endoscopists? So as per the guidelines, at least 20 US guided therapeutic procedure required for a reasonable skill. We have done at least 40-45 cases of US drainage, US choledochore duodenostomy, and US guided hepatogastroscopy. And another reasons are the poor visualization because of pouring of pus, inability to focus and visualize LAMS because of rapid partial collapse of cavity, and poor visualization of markers of LAMS. These are the reasons for. If you see the what next and what to rescue. If you see the literature, just published a review, where showed at least 2% of LAMS are misdeployed during the pancreatic fluid drainage. And rescue can be possible in more than 95% of cases, and techniques available are the over-the-wire deployment of a new stent through the created fistular tract, or if stent is partially visible through the gastric lumen, so you can place stent inside the stent. Although there is no consensus. And US guided separate puncture and altogether separate is a little difficult because already cyst usually collapse at that time. So we decided the over-the-wire deployment of new plastic stents with the already created fistular tract. So we initially started with the US guided because US guided deployment, but it was difficult to place a wire But when we use this change the US and we use the side view duodenoscope, then ultimately we are able to place the wire. So finally, duodenoscope guided over the wire deployment of a 2 DPT stand. Plastic stands were placed, and here you can see in the final video. So we can see the misdeployed lamps and as well as the plastic stands, the acoustic shot of the plastic stands. This is the misdeployed stand, and this one is the misdeployed, properly placed plastic stand. So then other conservative treatment were continued and patient improved, and follow-up CT scan here you can see the collapse of the cavity and in situ stands both metal and. So as conclusion, lamps deployment have been reported for pancreatic fluid drainage. A repeated US guided drainage can be very difficult, so better not to try that. Over the wiring appears to be the better than other modality for the rescue. Case 2. Obstructive jaundice after endovascular treatment of a gastroduodenal pseudoneedling. Don't trust for clear stenting. Disclaimer, this case was selected for oral video presentation in Hong Kong, and last month we just presented. It's a new observation. The formation of a pseudoneedling is a rare complication of chronic pancreatitis. Pseudoneedlings are usually treated with endovascular repair using expanded polytetrafluoroethylene, grafts or coils or the thrombin. The bile duct can be compressed by the thrombosed GD and urine, result from the endovascular repair. A 26-year-old male presented with a melena, examination revealed pallor, lab showed hemoglobin of 8 gram, CT angiography showed pseudoneedling of approximately 3 cm on side and evidence of chronic pancreatitis. The patient received 2 units of blood transfusion, and endovascular of pseudoneedling was performed not by our department, by the cardiology department, and graft was placed. 3 days later, the patient developed mild abdominal pain and yellowish discoloration of urine. Examination revealed jaundice. The lab showed again anemia, neutrophilic leukocytosis, hyperbilirubinemia, hypertransaminasemia, and renal and hospital. Transabdominal ultrasound revealed dilated bile ducts and ISBRD. US done, we showed a thrombus GJ pseudoneedling of approximately 4 cm size that was compressing this lower end of the CBD. You can see in the left panel, and in situ EPT graph you can see in the right panel of US image. Because patient had stable vitals, no fever, so therefore immediate biliary decompression of PRCP was deferred. Patient was treated with conservative therapy, including ibuprofen and antibiotics. Jaundice begins to improve after 2 days, and after 7 days, jaundice becomes 3.5. Ultrasound showed normal HBR. So patient was treated conservatively. So discussion: we were unable to find literature regarding the bile duct obstruction caused by a thrombosed GD pseudoneedling resulting from the endovascular repair. We also didn't find regarding the spontaneous resolution of thrombus GD and urine. However, the spontaneous resolution of portal vein thrombus and right atrial thrombus have been described before. If you see the natural history of deep vein thrombosis mouse model, so after the initial insult on day 4, thrombus become maximum and size of the thrombus become maximum at day 4, and thereafter it resolves naturally thereafter. And day 12 serving as a measure of thrombus resolution. So therefore, the pressure effect of thrombus pseudoneedling likely to occur maximum 2 to 4 days and diminishes thereafter. We have also another observation. It's a separate case just for the a patient had WOPN with aneurysm, and 2 weeks of follow-up when we did in the US, it was thrombosed, and after 4 weeks, thrombus resolved spontaneously. So in day-to-day life, we frequently see the spontaneous thrombosis and spontaneous resolution of. So to summarize the case of this patient, the timeline of the clinical course of this patient was correlating with the natural history of the DVT. So therefore, to conclude, the jaundice due to bile duct compression can result from thrombus pseudoneedling. The spontaneous resolution of thrombus can relieve the compression of bile duct. To avoid unnecessary RCP, in the absence of cholangitis, immediate decompression of biliary tract can be deferred for at least 1 week. So sometimes doing nothing is better for the patient. Thank you.
Thank you, sir, for your extensive deliberation. May I request you to please be seated on the dais. Our next speaker for the session is Dr. Sanjeev Verma, Senior Gastroenterologist at Das Hospital, Patna. May I request him to kindly begin with this topic.
Director, respected chairpersons, respected seniors and dear colleagues. First of all, I would like to thank Dr. Vijay Shankar who gave me this opportunity with this topic of obscure GI bleeding, which is really a difficult disease, and no one wants to have a patient of obscure GI bleeding in his or her clinic because it's time consuming, requires mental and physical labor, finances are involved, and the result is many times frustrating with recurrent bleeds. So let us come to the definition. The traditional definition of obscure GI bleeding is the presence of GI tract bleed with negative EGD, colonoscopy and a small bowel syringe. But this leaves a large area of small bowel that is like a big bloody black box that we really didn't have access to at that time when this definition was made. But with the advent of new technologies, we can visualize the entire small bowel and the more apt classification of GI bleeding should be upper GI bleeding, that is accessible by upper GI endoscopy, colonic bleeding, that is accessible by colonoscopy, and the rest in between is small bowel bleeding. Obscure GI bleeding terms would be reserved for the cases where a bleeding source cannot be identified despite a complete comprehensive workup of the small bowel. So in cases of GI bleeding, almost 90% of cases can be detected, the source of bleeding can be detected by EGD and colonoscopy. The rest 10%, the source of bleeding is suspected to be in the small bowel. Out of those, about 70% can be detected with the workup with newer technologies. Rest remain in the category of the obscure GI bleeding. The most common cause of small bowel bleed is mostly vascular malformations. Let us discuss a case. An elderly female, hypertensive, develops macrocytic anemia, denies frank blood in the stool, is found to have low iron, fecal occult blood test is positive, and has a normal endoscopy and colonoscopy examination. So this patient is having occult GI bleeding and the possible source is small bowel. What to do next? We have a long list of diagnostic options and it's very confusing. What to choose, what not. So let us see what the ACC guidelines say. This guideline is slightly older but is fantastic and worth reading. It suggests that if you have a patient of suspected small bowel bleeding, either occult or overt, you repeat an endoscopy. So studies looked at the use of second look endoscopy. They did it by using a push endoscope or a capsule endoscopy or double balloon endoscopy. And the diagnostic yield varied from 3% to 26%. So this may be useful to repeat a second look endoscopy. And it also depends on the fact that when was the last endoscopy exam made, what was the quality of the last exam, and who did that, what was the finding, whether it was totally normal or there were some suspicious lesions, and what is the character of bleeding now, whether it is still occult or has become overt. So when you decide for a second look endoscopy, whether it should be done by post endoscopy or by other methods. A retrospective study showed that patients of a suspected small bowel bleed who underwent post endoscopy with or without a capsule endoscopy. 155 patients underwent push endoscopy and 75 patients underwent both push and capsule. The indications were quite variable and the diagnostic yield of push endoscopy was 30 patients. And in patients with prior capsule endoscopy, there was no additional or missed lesions found on push endoscopy. So what is the role?
So we consider push endoscopy in patients who have a negative capsule endoscopy and still has a high suspicion of small bowel lesion. Because capsule endoscopy, due to its rapid transit through the duodenal loop, is not very ideal to detect the lesions in the proximal small bowel, especially duodenum. And it also provides the therapeutic adjunct. If you find a bleeding source, it can be tackled with the push endoscopy. So we have done a push endoscopy and it is still negative. If it is positive, treat accordingly. If it is negative, then the ECG guideline recommends proceed with small bowel evaluation. For small bowel evaluation, if you do not suspect small bowel obstruction, then proceed with capsule endoscopy. If you suspect a small bowel obstructing lesion, you can go for CT enterography or MRI enterography. Video capsule endoscopy is the test of choice according to ECG guideline for assessing the small bowel, because it is relatively easy to perform and can visualize the entire small bowel in almost more than 80% of the cases. Overall diagnostic yield in various studies varies from 38 to around 83%. Meta-analysis of 10 studies showed that the full diagnostic yield was around 62%. And another systematic review also indicated that the diagnostic yield was around 61%. So, if you have done a capsule endoscopy and if this is also negative, then we need the help of radiologist, and where he can offer us CT enterography. This allows the great resolution of the small bowel lumen and without any overlap of the intestinal loops. It may sometimes also show the blood in the lumen. And the punchline is that it is highly sensitive for detecting mass lesions and mural lesions. Because a person like me who reads lots of capsule is really worried about missing a mass lesion on capsule endoscopy. So, if you find a lesion on CT enterography, we treat it either by deep endoscopy or by surgery. If you do not find the lesion here, what to do after the negative CT enterography and capsule endoscopy? A negative capsule endoscopy is a very good test for ruling out a small bowel lesion and has a very high negative predictive value. Rebleeding rates after a negative capsule is very low. But false negative rates have been reported in some studies for a mass lesion up to 19% and for overall lesions up to 11%. So it is very important. We can use both capsule endoscopy as well as CT enterography, could be complementary to each other. If there is ongoing bleeding and suspicion for a missed lesion is there, then re-workup is indicated, be it repeating endoscopy, repeating a capsule, or further cross-sectional imaging. If there is no evidence of ongoing bleeding, both the ACG and ESG guidelines support wait and watch policy. If we have time, we can discuss one more case. Okay, so this elderly male is having 1 week symptoms of weakness and passing dark stools. He is stable hemodynamically, hemoglobin is 8.5, and on digital rectal examination, melanic stool was detected. EGD and colonoscopy could not show a source of bleeding and remains stable, but hemoglobin drops further. So this patient is having, that patient was occult GI bleed. This is overt acute, or you may say subacute GI bleed suspected from the small bowel. So what to do? Again the long list of options, but here the second look endoscopy is not required. So let us see what is the ACG recommendation. If the patient is unstable, stabilize. If it is stable, consider a capsule endoscopy or a CT enterography. Let us see this study. This evaluated the diagnostic yield of capsule endoscopy based on the timing of the exam in overt acute GI bleeding. You can see when the capsule was done on an emergent basis, that is within 48 to 72 hours of negative endoscopy and colonoscopy, the diagnostic yield was very high. as against the elective capsule endoscopy that was done about after 2 weeks of bleeding episode, and the diagnostic yield drops down significantly. This study, which showed the diagnostic yield of capsule endoscopy in inpatient setting for acute overt small bowel bleeding, that was done within 48 hours of the negative endoscopy and colonoscopy. In most of the patients, either blood or lesion was found in up to 75% of, up to 91% of cases. And this translated into the therapeutic yield either by endoscopy or surgery or by radiologic means in a wide, very large number of, significant number of cases. So capsule endoscopy is the test of choice because, as already said, it is easy to do. CT interrography is not used much. CT interrography we do only when there is ongoing bleed and the capsule is negative, and we find a lesion, we target it by device-assisted interroscopy. And the guideline suggests the same. You can do, if you find a lesion, and even if you don't find a lesion and you suspect that the lesion is in the proximal small bowel, you can proceed with deep endoscopy. Multiple techniques. First of all was double balloon endoscopy. Sorry for the spelling mistake. Then came single balloon endoscopy, then spiral, and now it is motorized endoscopy is in vogue. The success rate for total endoscopy varies between 16 to 86% for double balloon endoscopy. Diagnostic yield for a small bowel bleeding range from 50 to 80%. And successful intervention, therapeutic intervention can be offered in about 40 to 73% of cases. Complications rates are low, but re-bleed rate at the 1 year is significant. This is because most of the lesions treated here are vascular, and that can be either multiple or can recur. A meta-analysis comparing the diagnostic yield of capsule and double balloon showed that the diagnostic yield is similar. Another meta-analysis indicate that there is a similar diagnostic yield of video capsule endoscopy and double balloon endoscopy. But if a double balloon endoscopy is done after a capsule endoscopy, the diagnostic yield increases up to 75% if the capsule endoscopy is positive. So, what should be done? Should we do first a double balloon or should we do a video capsule? The advantage of doing the capsule endoscopy first is it is non-invasive and quickly, has a high diagnostic yield and has a high negative predictive value, and it helps in guiding the further treatment plan. But disadvantages are there is no therapeutic capabilities. Again, if you find a lesion, it leads to invasive procedure for therapeutic intention. It takes time to read the video and interpret, and majority of lesions are found in the proximal small bowel, which can be reached by double balloon endoscopy. And if you do both, the cost definitely becomes high. So, if the patient is having subacute bleeding, we do a video first, capsule endoscopy first. If the capsule is negative, we wait and watch. If the patient is having brisk ongoing bleeding, we proceed with deep endoscopy. The efficacy of double balloon endoscopy in acute bleeding has been found if it is done in urgent basis. Diagnostic yield is 70% as compared with 30% if done on non-urgent basis. Therapeutic yield is also high and rebleeding rates are low if it is done on urgent basis, that is within 72 hours of the last bleeding episode. So that the various choice of endoscopy matter. A systematic review comparing double balloon and single balloon showed that there is no statistically significant difference in the diagnostic yield, in therapeutic yield, in failure rates, adverse events, and complete endoscopy. So any modality of endoscopy, push endoscopy, deep endoscopy, there is no significant difference. So what to do? If we find a lesion, we treat it with endoscopy. If we do not find a lesion, then we again need the help of radiologist. CT angiography we can offer, and this has a very high sensitivity for detecting active GI bleeding. especially if the bleeding is active and is significant. A negative CT angiography has a very high negative predictive value, maybe 1 or 2 slides more. And if the CT angiography is negative, we can wait and watch, no further intervention. And if the CT angiography is positive, definitely the radiologist would like to go for angiography and transarterial embolization. It provides directed therapy, and with provocative maneuvers, it can localize the bleeding source accurately and can leave markers for the surgeon if the bleeding cannot be stopped at the transarterial embolization. But this has a potential complications of thromboembolic events and bowel infarction, so should be advised with caution. Lastly, the intraoperative enteroscopy. When a small bowel lesions cannot be localized by a non-invasive measures, then this is the only option. If the patient is bleeding actively and no other investigation is able to locate the source of bleeding, or if the patient is having some adhesions and enteroscopy and other maneuvers cannot be done, then intraoperative enteroscopy should be resorted to. It has a very high morbidity and mortality, so it is the last resort, not the first. Thank you.
Thank you, sir. This would be my request for our chairpersons to please come forward and award our speakers with some memento of appreciation.
We now wind up our pre-lunch session of the day. We would request our delegates to please join us for the lunch, which will be served on the 3rd floor in front of Vascular Science Department. Thank you everyone for your presence.
For the sessions. We hope the lunch have been refreshing. Continuing with pre-lunch sessions related to endoscopic conditions, may I have the honor to invite on the dais our chairpersons for the 20th sessions of this conference. Dr. Ashish Kumar Jha, Senior Consultant Gastroenterologist at IJNS Patna. Dr. Vijay Shankar, Consultant Gastroenterologist at IJNS Patna. Dr. Shantanu Mohan, Consultant Gastroenterologist at Patna. Dr. Avnish Kumar, Gastroenterologist at Ruben Hospital, Patna. Dr. Ravi Keshri, Consultant Gastroenterologist at Muzaffarpur. May I call upon Dr. Deepak from Begusarai to please come up on the dais. May I have the honor to request our speaker of the session, Dr. B.D. Goswami, to please come on the dais. Dr. B.D. Goswami is one of the best gastroenterologists in Ganeshpuri, Guwahati. His skills and expertise lies in liver, hepatitis B, liver diseases, hepatocellular carcinoma, cirrhosis, liver transplantation, etc. His topic for discussion will be artificial intelligence in GI endoscopy. I would request him to please begin with this speech.
Respected chairpersons and my dear friends, at the beginning I must thank the organizing committee for inviting me for this. For 15 minutes I will be speaking on the artificial intelligence and how it is incorporated in GI endoscopy and what is the situation or position as of now. So from 1960, when it got 2000. Now after that, so many innovations are coming up, which endoscopy seeing more and looking at more and more specific in endoscopy in GI tract. And finally today, what we have got. Today we have got the artificial intelligence attached to the endoscopy. And that's why we have got the Fujiscope with AI. We have got the Olympus X1 scope with AI. And these are the ultimate and game changer in GI endoscopy as a whole. So artificial intelligence is an integral part today in most of the aspects of our human life. And now it is coming to gastroenterology and mainly the gastroenterology endoscopy. So basically this is a new eye, you can say a new eye to the endoscopy or the physician, so that he see more and more. So what is the definition of artificial intelligence? This is basically any machine that shows any intelligence, that is artificial intelligence. Today it has got the ability for a computer or artificial intelligence to think and the learning process. So that is the beauty of artificial intelligence. So it has revolutionized the whole endoscopy system today, as of now. In future probably this coming more and more. So what we have got with endoscopy, with AI, we have the predictive analytics. You can predict the disease process even. We can see the quality control of the endoscopy. It augments the documentation. It identify or detect any lesion in the GI tract. It can classify or characterize the lesion, what it is, malignant or not malignant. And also finally, you can plan the treatment for the patient with the help of the artificial intelligence. So already it is coming up in endoscopy, mainly in the colonoscopy. It is working and growing definitely. And for that matter, two things are coming up. One is your computer-aided detection, CAT-E, and another is the diagnosis, CAT-X. So you can identify, detect it, and finally you can characterize it. That's what two parts of it. So what happens in AI? In AI, we have got the input from different sources, from pictures of images, clinical data. Everything will be given to the computer. It will go for the data processing, that is called the machine learning. And next, it will one process, it will give the hints or diagnosis, neoplastic or hyperplastic. Similarly, we have the deep learning. So computer with the neural network work more and more, and it can read and it again can give you the hints that the process is what we have got. So in colonoscopy, we have got the problem that is a concern for all of us, is that any lesion is a hyperproliferative one. It can be adenomatous polyp, small or large one, dysplasia, adenocarcinoma, or the invasive cancer. So here is the data what we have got. So for example, the patient has got the tubular adenoma, tubular villus adenoma, or serrated adenoma, any lesion. We have got almost 2.5 to 40% chance of having malignant cells along with that one. That's why always we should be careful about it. Also, we now know that adenoma detection rate is the ultimate criteria for a good or indicator of the colonoscopy. And also this is the fact what we have got. If there is 1% increase in adenoma detection rate, means almost 3% reduction or prevention of colorectal cancer. So that's why the importance of detecting a lesion in the colon is important one, and how ultimately AI can help us. There are challenges in the colonoscopy. Why? Because the whole endoscopy, upper GI or colonoscopy, is physician dependent. Who is doing the endoscopy, it depends upon that particular person, and everybody is not an expert one. Then number two is the colonoscopies get tired over the time. For example, somebody is doing colonoscopy in the morning or upper GI endoscopy in the morning, in the evening, again the same person, if he is doing the same procedure, almost 14% reduction is success rate goes on. So that's why the difference is there. And all the lesions in the colon are not visible to the naked eyes or the endoscopic eye. So if suppose it is behind the folds, if it is a small one, if it is a flat polyp, so it is difficult to see or diagnose it or detect it. So that's why actually we have got this detection with AI, what we call the CAD-E. So already so many studies, I'm not going details about it, showing clearly this study from China. 1058 colonoscopy was done, and they have shown that polyp detection rate, adenoma detection rate everywhere. They compared with the routine colonoscopy and AI. So with AI, definitely it has got much better result. You can detect more and more. Again, this study coming from Italy, almost 658, 85 patients. Similar way, there is advantage of AI related colonoscopy which will give you the better result. This study from US again showing the missing rate, adenoma missing rate is grossly reduced if you are using the AI related colonoscopy. So this is another study again from Europe for colorectal neoplasia. Again, the better result we have got with the AI. So always it is better to have the AI. This is another slide I am showing with RCT meta-analysis and the systematic review again, the advantage of ADR, polyp detection rate with the AI. Now AI is trained to predict the inflammatory process. For IBD, for example, with endoscopy, with colonoscopy, it can predict. What it can predict? Ultimately, which particular medication should be given to the patient, even escalation of the treatment, whether it is needed or not needed, surgery is advisable or not advisable, and also the mortality it can predict. So this is process also can be predicted with colonoscopy, with AI. So this slide I am showing, if again AI can help us in ileocecal valve, I mean whether you are already there or not, you can identification, or also the withdrawal time. AI can direct us whether it is good enough or not. For example, this slide, yes, here in this video you can see, so the it is in the ileocecal valve, and here is the indicator. In the side screen indicator will show you withdrawal time is a faster one or you are crossing the limit. If it is a very fast one, you can miss something. So AI will dictate you that you are out of the range or you are in the range. So that's why AI is very important for us now. So even AI can predict about the bowel preparation. These are in studies, I am not going in details in colonoscopy. So coming to our own experience, for example, here, this patient, this is Olympus X1 scope. So here we have got the lesion, but with AI, even if you miss it, but here this here you can see the AI will show indicate that there is something, is giving the signal to the endoscopy that be careful about the lesion is there. So after that you go for NBI mode, or even if it is a Fujiscope, this is the NBI mode, you check it and try to ultimately sort out or recharacterize the lesion, whether it is malignant or is a non-malignant one. This is another video I am showing with my experience what happens. Suppose here the side screen AI is showing that there is something, and okay, you now check it here, we have got a lesion. So with NBI we try to characterize it with the Olympus scope. So next, more than that, we have the best thing coming up with AI, detect the undetected. Even during the colonoscopy, you are missing something. Very rare, very frequent it happens, because miss rate in colonoscopy, total colonoscopy is almost 22 to 26%. So that's why if you use this procedure with AI, you may not miss anything. So for example, GI Genius from Medtronic, yes company, they have got the AI, and what they tried, they trained the computer to automatically give the diagnosis, any shape, any morphology, any size. So this polyp, they have got the success at 99.7% to detect it. Almost 82% faster polyp detection if you compare with the without AI. So this is what our own experience, for example. Here again, it is very small polyp, but the side screen with the green tag, it is showing blinking that there is something, so you don't miss it. That is the detect the undetected one. So here again you see a small lesion, almost flat lesion. The AI was signaling, I checked it and give the NBI mode, and clearly it is coming up. Then again, this is another video. I'm not going details, but you see the signal is coming up, and here is the lesion. We'll try to characterize the lesion. So characterization is the next step, and already it is coming up in a big way. For example, in Fujiscope, they have got the K-dye, and where they have got the chance to characterize the lesion. So they have got the LCI mode, BLI mode. With the LCI mode, you can detect the lesion, but with the characterization BLI mode, you can use it, you can get it. So here, how they do it, with the automatically whenever they get a lesion, so it will automatically check, and whole picture will be encircled by green one. That means it's a hyperplastic one. But if it is a yellow color coming up at the last one, then means it is a malignant one. So coming to this video clip, you can see here. So there is a lesion, a polypoid lesion, and the AI into the trying best to characterize it, and finally they are giving the result that it is yellow colored, already is having the mapping here, that means it is something wrong, and here we have got the yellow color encirclement, that means it is a neoplastic lesion. So automatically AI will help you in finding out the solution. This is another case. When I found this lesion, I checked it, AI was initiated, and immediately we got the diagnosis that it is a hyperplastic lesion. Then again, this is another lesion, I got it, and we tried. AI was trying initially, it was giving the diagnosis that it is a hyperplastic one, but finally it gave the diagnosis that it is a neoplastic one, because final encirclement is not coming till now. It is on the process. I am not going in details about that. This is the picture again showing the real-time characterization of the polyp by AI. The sensitivity, specificity is very high, definitely it is very useful one. already AI is in the upper GI tract today. Earlier it was in lower GI colonoscopy, now it is coming in a big way. Fuji has got already launched this in India, and we can use it now for any detection of malignancy in upper GI tract. It is already available. The studies coming from abroad, all the European countries, in America even, they have even a lot of works are on Barrett's esophagus. Then this is the depth of the gastric cancer with AI. Slide they are showing how better position. Again, recently from Netherlands, this study was published, and the system, mainly AI systems, show promising results to get the detection also up to 99% cases. 99% cases with AI you can detect the lesions, mainly the carcinoma of the upper GI tract, esophagus, or in the stomach. Even if it outperform the expert ones also in detecting a lesion, mainly in the esophagus and the atrophic gastritis. So gradually, probably in future, most of our daily life also will be having a AI assisted life. So this is the exciting moment today. I was given the question where we stand today. Here we are showing we are here only now. Earlier, initially, AI was a bit lesser, lower than the human brain. Specifically, now coming up in the current status, the narrow task specific AI maths even the human brain today. But in future, probably the AI will take over, or most of the time it overshadow the human brain. So AI, the big question about will AI replace an endoscopy? Definitely not, because there are so many reasons AI needs an endoscopy. For mucosal exposure, for the preparation. So all these matters, the endoscopies have to give the focus, the picture clear to the AI, then only it can give the diagnosis. So in summary, AI is already here. CAT-E system easily can diagnose or detect the polyp. CAT-X give the characterization easily now everywhere, and RCD trials show substantial benefit of adenoma detection. The rapid clinical adoption of the AI technology is on the process, and it is important on all of us. Ultimately, we have to go through it, and probably further more and more will be coming up with AI. Thank you for your kind attention. Thank you.
Thank you, sir,
Thank you, sir.
for the wonderful session.
Sir, excuse me. Sir, do we have any condition in which right now human intelligence supersedes AI?
Yes, already I have shown that as of now we are in a situation slightly it is overshadowing the human brain. I am showing in the slides in different ways from different countries. The studies are clearly showing that suppose we are doing a colonoscopy or an endoscopy, we can miss it. But AI is not missing. I am showing in my slide, in my experience itself, I have got both the I have got the experience with the Olympus. So if you miss also, so AI will not miss. AI will give the indication.
I am asking, does human intelligence
Yeah.
supersede artificial intelligence in any condition? There AI is superior to all.
Yeah.
Is there any condition in which we supersede?
That probably it will be difficult one for future, we don't know. Already you have seen in the day it is coming up, the people are worried about AI today, because probably it will be a big problem for the future, because AI may overshadow or it supersede the human brain. And if somebody is utilizing it in a bad way, it will be disastrous for the future. So that's the most of the experts who actually introduce AI, they are worried about the future.
Dr. Vijay, we are putting the AI, we are giving our brain to AI. AI is not giving us the false negativity with the AI. If you do AI in the ulcerative colitis, it gives the adenocarcinoma. It is the false negativity. Second thing, unnecessarily import the box. So your colonoscopy time is increasing. Soon I am also having the AI in my center also. But these are the false negativity of the AI. Still, AI is not available in upper GI. They are telling that in 3-4 months it is available in India, but still it is not available.
Yeah, this is not a side effect. You cannot say the side effect, but we should be concerned about sometimes the false positive and false negative. For example, we are doing the colonoscopy. The stool material is here. It can definitely make a difficulty in proper recognition. So we should be careful about the endoscopy. That's why the endoscopy brain have to apply that particular time, whether we will ultimately accept this AI result or we have to have our own result.
Thank you everyone for your involvement. We would like to request our chairpersons to present the memento of appreciation to our speaker and join in for a short photography session. Moving on to our next session of the day, may I have the honor to invite the chairpersons of the next session, Dr. Nikam Prakash Narayan, Pediatrics, Patna, Dr. Vineet Kumar Thakur, Head of Department of Pediatric Surgery, IGIMS Patna, Dr. Shrikant Pandey, Pediatric General Enterologist, Patna, Dr. Arya Sushmita, Pediatric Gastroenterologist, IGIMS Patna, and Dr. Manish Kumar Bhaskar, Gastroenterologist, Parasochamarai, Patna.
Now I would like to request our speaker of the session to kindly come up on the dais, Dr. Vikram Sundari. He is currently pediatrics hepatology at ILBS, New Delhi. He has been instrumental in establishing a fully functional pediatric hepatology unit which is well equipped with prompt management of infectious, metabolic and hereditary liver diseases. His topic for today's discussion is how to approach jaundice in children. I would request him to kindly begin with this topic.
Thank you, chairpersons, and thank the organizers for giving me this opportunity to present this topic. So, the topic is jaundice in a child, how to approach. It's like trying
Before you start,
Yes, sir.
I think it's our privilege to chair this session of yours because, in fact, these cases first come to pediatricians. So that's why I'm privileged to chair this session and invite you all for this occasion.
Thank you.
So I think this is important for all of us to know about the jaundice and how to approach it. Thank you.
Thank you. So, giving a talk on this is like summarizing all I have learned in last 12 years or so in 15 minutes. It's absolutely impossible. I'll give it a shot. So, so there are no conflicts. So, what exactly is jaundice? You see a child, he says my eyes are yellow, my urine is yellow. So that is how you first suspect that a child may have jaundice with a yellow discoloration of eyes, skin and mucous membrane. So the first and foremost question, so it is like, these are the questions that come to my mind when I see a patient with jaundice. It's not going to be a textbook lecture, ये किसी book में नहीं मिलेगा आपको. So this is how I proceed when I see a patient in the OPD. So there are a couple of questions that I ask myself. That the first and foremost question is, whenever I see a patient with jaundice, the first thing I ask them, what is the urine, the stool color? So if they say it is dark urine, then I would realize that it is somewhere falling here, then it is a conjugated jaundice. and this is where my expertise or my area of interest is. If they say the urine is normal color, eyes are yellow, but the urine is normal color, it's not dark yellow or dark brown, then you will realize that it is most commonly you are dealing with unconjugated hypobilirubinemia. Then you go on evaluating for hemolysis, Gilbert's and all other disorders. So this is your question number 1. What is the urine color of a patient who presents with jaundice? So if it is dark urine, I as a hepatologist would like to work up these patients further. So now we are only going to deal with conjugated or direct jaundice. So there are these, the second and the third questions are these. So if it is jaundice, if it is a liver based jaundice, I am only worried about two things. Whether it is an acute jaundice, that is my question number 2, or it is a jaundice which has an underlying chronicity. So you may have a patient of Wilson's disease which is a cirrhotic CLD, he may present with jaundice also, first time. You may have Wilson's, on top of it you may have hepatitis A or some other infection. So my question number 2 is whether it is acute jaundice. Question number 3 is with or without underlying chronicity. So these are the only 3 questions that you have to answer when you start evaluating your patient. So we'll try and evaluate all these 3 questions when we go further. So acute jaundice you may have because of infection, you may be it because of drug induced injury, you may have infections like malaria, typhoid, whatever you want to call it, or some biliary sepsis. Chronic liver disease, any liver disorder which you may have underlying liver disorder as a chronicity, Wilson's, autoimmune, viral hepatitis, polycystic disorders like PSC, PFIC, blood carrier syndrome, they may also present with jaundice as the first presentation. So you may have a Wilson's disease coming with 7 days history of jaundice. So that is how you should work out. First establish whether it is acute jaundice. Third question is on top of this acute jaundice whether there is an underlying chronicity or not. So acute jaundice, the most common cause is acute infective hepatitis. Most commonly are the markers we have highlighted, hepatitis A, hepatitis E and hepatitis B. The rest are not very uncommon. Dengue season you may find very patients of dengue coming with jaundice. So dengue virus, some other viruses you may find out. Most common causes in India are hepatitis A, most commonly along with hepatitis E and hepatitis B. But what you have to realize is they may appear in combination. So you may have patient who has hepatitis A plus B, A plus E, A plus E plus B. We have seen all sorts of combinations. So once you start evaluating, don't just send IgM, HAV. Send A, E, B at least simultaneously. So the learning point here is always exclude at least these 3 common causes in all AVH cases. By practice, I also do anti-HCV, but hepatitis C is a very less common cause of acute jaundice. But just to pick up the silent and chronic cases, along with this, my practice is to also exclude hepatitis C. But the problem here is that once you see a patient of acute jaundice, the most of the prescriptions that we see in North India, they would write HBsAg, anti-HCV and LFT. That is the most common issue. So please do exclude this IgM, HAV and IgM, HEV in all these cases. Always do a complete evaluation for co-infections, and if these come out to be negative, then only go ahead with other viruses like dengue, CMV, EBV and other viruses. So the most important test, can you tell me what is the most important test once you start working out for a patient of acute jaundice? One test, PTI. Not HAV, not the serology, not the LFT. The most important test which will actually help your patient is PTI. Because if you have a patient who is saying that I have dark urine, I have yellow eyes, I don't even need a LFT. I know it is a conjugated jaundice. Whether it is bilirubin is 10 or 20, that 20 or 50, whatever, how does it matter? The only thing which matters is patient should not go into liver failure. You have to pick up these cases early. So mostly, majority of them of acute infective hepatitis would improve on your own. Some may have atypical presentations like cholestatic jaundice, relapsing course. One episode would go, another episode would start. Some may also have ascites, they may have co-infections, they may develop hemolysis. Majority of them would recover on their own. Less than 1% would actually go into liver failure. What is the differential diagnosis of acute jaundice? More than 90% of the cases would come out to be infective or viral infections. Malaria causing jaundice, typhoid causing jaundice, leptospira is still exception,
malaria and typhoid usually do not cause acute jaundice. They may present with other features like severe anemia, persistent fever, or other disorders. Malaria typhoid presenting as clinical jaundice is a rare phenomenon. Biliary sepsis, liver abscess rarely. Most common causes, so I have already told you that chronic liver disorders like Wilson's, autoimmune may also present as acute jaundice. So they should always be kept into differential diagnosis, especially if your hepatitis A, hepatitis E, hepatitis B markers have come out to be negative. So when do you suspect malaria, typhoid and leptospirosis as a cause of acute jaundice? If you have high grade persistent fever. That's not a cause with acute jaundice, acute viral hepatitis. Associated severe anemia, some viral prodromic like features like conjunctival redness, oliguria, skin rash, features of dengue shock syndrome, thrombocytopenia. Most of the causes in malaria, typhoid, dengue, they would have minimal to mild icterus. Jaundice will roughly be less than 3 or 4 or 5, something like that. Enzymes may not be very high except if they go into ischemic hepatitis. So typical feature of a malaria, typhoid or dengue presenting with LFT would be, bilirubin would be roughly around less than 5, enzymes would be roughly around 300, 400, usually they are in thousands in acute viral hepatitis, and AST usually more than ALT in these cases, and they have high CPK and LDS because of other concomitant extra hepatic involvement. And they may coexist. So what is the general treatment of AVH? It is a parental reassurance and doctor's reassurance also. Normal diet, plenty of fluids, no medications are needed. So can you tell me, what do you need restriction on diet? No. Do you need a bed rest? No. Patient can run, patient can do whatever they want. Do you need any restriction on namak, tel, ghee, haldi? No. No herbal medication intake, no glucon-D intake, no ganne ka juice. Please remember that. But it actually does is causes gastritis, patients start vomiting again and again. Don't force them to take glucon-D. So nothing is required, not even Udiliv. We give it because we do not have anything else to give. It's just a placebo for them. There are no indications of using any drugs. But in my practice, if you want to give them a multivitamin, maybe you can give them Udiliv. It's still an expensive drug, but assure them that majority of them, 99% would improve on their own. There is no need of this, there is no need of this, no need of this, nothing is needed. So when do we suspect? This is my question number 3. If in a patient of acute jaundice, you suspect underlying CLD. If you have a chronic history, you have a patient of growth failure, you have a family history of liver disease, you have a patient who presents with ascites and encephalopathy, you have find large liver, large spleen, ultrasound shows evidence of CLD. That is how you suspect. That is your question number 3, whether with this acute jaundice I have an underlying CLD or not. I'll rush through the slides. So there are multiple causes of CLDs. I'm not going into the details, but I rush through these slides. So the most common thing is, how do you start evaluating a patient when you suspect CLD? Don't start investigating randomly. If your patient comes to you in early age, 1 to 2 years of age, don't send Wilson's disease markers. Wilson's disease starts presenting clinically only after 3 to 5 years of age. So if you have an infant who has large liver and spleen, don't think of Wilson's disease. Think of other common causes, autoimmune, cholestatic disorders, biliary atresia. Wilson starts manifesting only after 3 to 5 years of age. There are some etiological pointers, I will show this later. So if you have a patient, Wilson's disease can present with any form. It can present with mildly raised enzymes, mild hepatomegaly, fatty liver, acute hepatitis, chronic hepatitis, cirrhosis, acute liver failure. So over last 12 years, I have seen all these presentations in individual patients. So they may just present you with a LFT जिसमें AST, ALT हाई हो. एक पेशेंट लेके आएगा रिपोर्ट जिसमें लिवर में सिर्फ अल्ट्रासाउंड में ग्रेस ने ग्रेड 1 फैटी लिवर लिखा हुआ है. ये सब प्रेजेंटेशन विल्सन्स की हो सकती हैं. तो हर CLD के पेशेंट में कैसी भी प्रेजेंटेशन हो, आपको विल्सन्स एक्सक्लूड करना ही है. ऑटोइम्यून कैसे आएगा? ऑटोइम्यून में मोस्टली जो कॉमनली हिस्ट्री होती है रिकरेंट जॉन्डिस की. अभी तो एक एक्यूट जॉन्डिस है, पीछे भी मोस्टली हिस्ट्री मिलती है एक्यूट जॉन्डिस की. और फैमिली में यूजली हिस्ट्री होती है कि उनको भी कुछ ऑटोइम्यून डिसऑर्डर्स है, लाइक थायराइड के डिसऑर्डर है, स्किन इन्वॉल्वमेंट है या पीछे थायराइड के इलनेस है. यूजली हम डायग्नोज करते हैं बेस्ड ऑन ऑटोइम्यून मार्कर्स एंड लिवर बायोप्सी. लिवर बायोप्सी इज अ मस्ट फॉर डायग्नोसिंग एंड मैनेजिंग ऑटोइम्यून हेपेटाइटिस. इफ यू आर नॉट एबल टू डू अ लिवर बायोप्सी, डोंट स्टार्ट देम ऑन इम्यूनोसप्रेशन, बेटर टू रेफर देम. प्यूराइटिस मोस्टली हम लोग PFIC या एलर्जिल सिंड्रोम देखते हैं. मोस्ट कॉमनली, नॉट वेरी कॉमन, जेनेटिक डिसऑर्डर्स हैं, इतने कॉमन नहीं हैं. इफ यू थिंक कि इसको पेशेंट को सिग्निफिकेंट प्लूराइटिस है, रेफर देम टू अ गैस्ट्रोएंटरोलॉजिस्ट एज अर्ली एज पॉसिबल. देयर आर सम डिसऑर्डर्स वी थिंक लाइक दिस, दीज आर, दे दोनों भाई थे, हिस्ट्री थी बेसिकली प्लूराइटिस, ग्रोथ फेलियर, जॉन्डिस की. वी स्टार्टेड इवैल्यूएटिंग देम, जीजीटी वाज हाई, एंड इफ यू थिंक इस प्रोटोकॉल में आप डालें हाई जीजीटी, अर्ली इन्फेंसी, पोर्टल हाइपरटेंशन है, you can suspect PFIC type 3. You do the immunoscreening, genetic test confirmatory होता है इसके लिए, आप confirmatory PFIC type 3. और disorders हैं low GGT, high GGT, cholecysticism, but these are rarer disorders. अगर आपको लगता है कोई ऐसे diagnose आप कर रहे हैं, better to refer them to a pediatric gastroenterologist. So to summarize, Wilson's हर disorder में, especially जिसके साथ neurological illness है या positive family history है, ये कॉमन टेस्ट आपको करने हैं. एट द एंड ऑफ द डे जेनेटिक कंफर्मेशन आजकल मैंडेटरी लोग कहते हैं, बट एटलीस्ट ये कॉमन टेस्ट आपको करने हैं. ऑटोइम्यून डिसऑर्डर है जिसमें यूजुअली रिकरेंट जॉन्डिस की हिस्ट्री है. फीमेल सेक्स मोस्ट कॉमनली एसोसिएटेड ऑटोइम्यून डिसऑर्डर है इन द पर्सन, इन द पेशेंट एज वेल एज द फैमिली. देन यू शुड थिंक ऑफ ऑटोइम्यून लिवर डिजीज. कॉमनली ऑटोइम्यून मार्कर्स आपको करने हैं. बायोप्सी इज अ मस्ट. क्रॉनिक वायरल हेपेटाइटिस हर डिसऑर्डर में आपको एक्सक्लूड करना है, हेपेटाइटिस बी एंड हेपेटाइटिस सी. कॉलिस्टेटिक डिसऑर्डर्स में पेशेंट अगर आपके पास इचिंग, पेल स्टूल्स विद और विदाउट फैमिली हिस्ट्री आता है तो आपको जीजीटी चेक करना है, अल्ट्रासाउंड करना है, बायोप्सी करनी है और जेनेटिक टेस्टिंग करनी है. जेनेटिक टेस्टिंग मस्ट है, क्लिनिकल डायग्नोसिस आजकल लोग नहीं बनाते हैं. बर्ड कैरी सिंड्रोम एक टिपिकल डिफरेंट चीज है. इसमें पेशेंट यूजुअली बोलेगा आपको कि पेट फूल रहा है. जॉन्डिस की हिस्ट्री मे और मे नॉट बी देयर. तो इसमें मोस्ट कॉमन जो डिसऑर्डर है वो है, आप डॉक्टर करें, डायग्नोस्टिक है, सीटी की भी जरूरत नहीं पड़ती है. अच्छा रेडियोलॉजिस्ट है, आपको अल्ट्रासाउंड के ऊपर ही बता देंगे कि दिस इज बर्ड कैरी. ट्रीटेबल इटियोलॉजिस्ट पे पहले फोकस करना है. तो अगर मेरे को कोई बोले कि इवैल्यूएट कैसे करना है सीएलडी के पेशेंट को, आई विल स्टार्ट में कुछ भी हो पेशेंट की हिस्ट्री, मैं पहले ये कॉमन कॉजेज जो होते हैं जो ट्रीटेबल है, एक फैंसी डायग्नोसिस बनाने का कोई फायदा नहीं है. वो इंस्टीट्यूट में बैठे बैठे लोग बहुत बनाते हैं, बहुत प्रमोट करते हैं कि हमने एक फैंसी डायग्नोसिस बनाया, बट ये पेशेंट को हेल्प कभी नहीं करता. अगर आपको पेशेंट को हेल्प करनी है, ऑलवेज थिंक ऑफ ऑटोइम्यून, विल्सन्स, वायरल हेपेटाइटिस, दीज कॉजेज, बिकॉज इसके लिए आप ट्रीटमेंट दे सकते हैं पेशेंट. और अगर आपको कोई पेशेंट ऐसे मिलते हैं, ऑलवेज ट्राई टेक एन एक्सपर्ट ओपिनियन, अर्ली रेफर these patients early to gastroenterologist. So this is the basic workup that we do, first line basic workup in all patients of CLD. So the carry home messages are, in a patient with jaundice आपको 3 क्वेश्चन पूछने हैं बस उससे. जॉन्डिस क्या कॉन्जुगेटेड है, यूरिन कलर पूछिए. अगर कॉन्जुगेटेड है तो लीवर डिसऑर्डर है. अगर लीवर डिसऑर्डर है तो क्या वो एक्यूट हेपेटाइटिस है. एक्यूट हेपेटाइटिस है तो आईएनआर चेक कीजिए वो लीवर फेलियर में है कि नहीं है और उसके कॉज आइडेंटिफाई कीजिए. और तीसरा क्वेश्चन जो मेरे लिए सबसे इंपॉर्टेंट है कि एम आई मिसिंग एन अंडरलाइन सीएलडी, कि कोई मैं सीएलडी तो नहीं मिस कर रहा हूँ. क्योंकि अगर इफ एज अ हेपेटोलॉजिस्ट मैं सीएलडी मिस कर दूँ तो क्या फायदा. तो ये 3 क्वेश्चन मेरी, जब भी मैं ओपीडी में बैठता हूँ तो मेरे दिमाग में यही 3 क्वेश्चन घूम रहे होते हैं कि कोई मैं ऐसा चीज मिस तो नहीं कर रहा हूँ. अगर आप स्टेप वाइज चलेंगे तो इट्स वेरी लेस लाइकली कि आप कुछ मिस करें. हेपेटाइटिस ए, हेपेटाइटिस ई कॉमनेस्ट कॉज है वायरल हेपेटाइटिस के, बट डेफिनेटली दैट्स व्हाट आई एम सेइंग कि एचबीएसएजी और एनटीएससी मत कराइए सिर्फ. वो सबसे लीस्ट इंपॉर्टेंट टेस्ट है कि कोई पेशेंट एक्यूट जॉन्डिस के साथ आ रहा है. मोस्ट इंपॉर्टेंट टेस्ट आर आईएनआर, आईजीएम एचएवी एंड आईजीएम एचईवी. वैक्सीनेशन हर पेशेंट को एडवाइस कीजिए. हेपेटाइटिस कोई भी आपके पास पेशेंट आता है, एज अ पीडियाट्रिशियन ऑल्सो आपको हेपेटाइटिस ए और हेपेटाइटिस बी की वैक्सीनेशन एडवाइस करनी चाहिए. लिवर फेलियर कभी मत मिस कीजिए. कोई पेशेंट एनकेफेलोपैथी में जा रहा है तो बहुत लेट स्टेज में पहुंच गया आपके पास. अगर आपने उसका आईएनआर स्टार्टिंग में करा लिया होता, जो बॉर्डर लाइन चल रहा है, हो सकता है वो प्रोग्रेसिवली इंक्रीज कर रहा है, तो इसलिए आपको हर आईएनआर, कुछ और टेस्ट कराएं ना कराएं, आईएनआर का टेस्ट जरूर कराइए. और सीएलडी जरूर एक्सक्लूड कीजिए अगर आपके पास कोई हिस्ट्री मिल रही है. एंड अगर कोई भी डाउट है तो अर्ली रेफरल इज द की. That is the last slide. Thank you.
Thank you very much, Dr. Mutterfut, for your excellent presentation. I think gone back over the days when we used to monitor the urine for their color themselves, but I think you are very categorically said that even that urine has got a significance right now also. So that's wonderful of you. I think there is one actually test in hepatitis which I think people have forgotten, was excess of urobilinogen. Well, that is the point actually that it is lost after some few days of onset of the disease, and then there is absent urobilinogen, and then there is again a rise which shows that there is an improvement which has started. So that has gone in the backdrop.
Yes.
Nobody does it.
I have never.
Yeah, so that was very important for you see in our days,
Yes.
3 to 4 decades ago, I'm telling.
Yes.
Because they were very significant. You have to monitor the uropilinogen level in the urine. So because of the tissue edema, hepatic edema, it used to completely go away and it didn't come in the urine. And then once the edema started resolving, then uropilinogen in excess again started coming up. So that was a very good clinical parameter to know about the improvement. I think you are very right that autoimmune cases must be monitored because this is very important. I don't know about the prognosis. I think I'll ask that question to you, but you just note down. And then there are a lot of cases of you see raised transaminases for months on years. I don't know how to deal with them. And I've taken a history, and sometimes they have been on some drugs, innocuous and Ayurvedic and homeopathy. I don't know whether they are playing their role.
Yes.
But raised transaminases unexplained, and it's very difficult to really console them that there is nothing there. And you should. Then I have got to say that you just avoid any drug whatsoever.
That's the first step.
So that's the one thing.
Yes.
I think it's very important. These are the important issues, and of course those syndromic illnesses. I've got one case of the unconjugated Gilbert's is just coming and going. There's nothing to do about it. So of course Kedler Nazar and David Johnson, they are also coming often. But I think majority of the cases, what you have told,
yes,
they are very, important for the practical approach of it. Yes. Thank you very much.
Thank you. Thank you.
Excuse me, Doctor. Very
Yes.
simple and quite precise. Thank you.
Thank you.
My question is, so the message is no diagnosis of autoimmune hepatitis or treatment of autoimmune hepatitis without liver biopsy.
Exactly. No doubt, sir. Mostly it's a lifelong treatment. You are not able to remove or take back these drugs in majority of these patients. So if it is a lifelong disorder, always be confirmed about it before you start.
You have missed neonatal jaundice.
So this
You
was
don't
in a
say
child.
anything
So,
of neonatal jaundice. That is the problem in neonate, in NICU and this.
the topic was only given to me for a child, sir. So that is great.
May I, Dr. Sud?
Yes, sir.
Very nice
Yes.
presentation. As a pediatric surgeon, I would like to ask,
Yes.
how early you should suspect this biliary atresia? Because by the time you people diagnose, early there is anything we people do.
Exactly, sir. That is our problem. Even as a pediatricians and pediatric gastroenterologists, we have failed in this sense that majority of time when we refer them to you, they are already very late. The biliary atresia, nowadays the concept has changed. You can diagnose biliary atresia in the first week itself. If you are very careful with your history, very careful with your direct jaundice levels. So the concepts in the West have changed. Now they are diagnosing and operating them within 2 to 3 weeks. We are still at 2 to 3 months. That's our problem. Our referral system is that bad. So there's nothing else we can do about it. We have been trying for decades, but this referral system has not improved in India. Sir, biliary atresia, yes sir. So biliary atresia, there is technically, I would say the only gold standard is RU as a pediatric surgeon when you do a cholangiogram. But it's a combination. There is no test which is confirmatory as for a physician. No ultrasound can tell you 100% whether it's biliary atresia. No liver biopsy is not 100%. Even we have now started doing per of cholangiogram using IR. People have started doing it. So all the tests in combination. If you find a patient who has a high GGT, pale stools, you do an ultrasound, you find some features, then you do a biopsy, and then you refer them to you. That if it any doubt, you will open up and do a cholangiogram. If it is there, you will operate. Otherwise, you won't operate. So that is, you are the gold standard step, sir.
Do we have any queries from our delegates sitting off the dais? Thank you everyone for your involvement. Moving on, we would like to request our chairpersons to present memento of appreciation to our speakers.
Moving on to our next session of the day, may I have the honor to invite chairpersons for the session, Dr. Programm Chaudhary, Obgyn Gynae, Patna, Dr. Himanshu Roy, Obgyn Gynae, Patna, Dr. Saurabh Jaiswal, Hepatology, Patna, and Dr. Rajiv Sinha, Gastroenterologist, Patna.
I would also like to request a speaker for the session to kindly come up on the dais. Dr. Meena Shaman, consultant gynecologist at Kurji Hospital, Patna. The topic for today's discussion is how liver matters for us. I would like her to kindly begin with the topic.
A very good afternoon to all of you. At the outset, thank you organizers, especially Dr. Shankar for inviting me here before this August gathering. So, liver matters to all of us. And let's look at the obstetrician's perspective. We know that any liver disorder can occur in pregnancy. Pregnancy can also occur in patients with pre-existing chronic liver diseases, portal hypertension, and to that list I would also like to add after liver transplantation. Liver dysfunction in pregnancy can also be secondary to pregnancy per se, that is pregnancy-related disorders, and this is what I'm going to focus most on. And these would include acute fatty liver of pregnancy, the HELP syndrome, that is hemolysis, elevated liver enzymes, and low platelets, the preeclamptic liver dysfunction, intrahepatic cholestasis of pregnancy, and in italics I have put hyperemesis gravidarum because it used to be included in the liver disorders but not any longer. Now it's rightly so included in the GI disorders. So I will not be talking of it in any of my further discussion. We have to remember how to interpret liver function test in pregnancy, which could be a little different from a non-pregnant person. Serum bilirubin, serum alanine and aspartate aminotransferase remain in normal range. However, there may be a decrease of about 25% in the third trimester. There is a mild increase which can be to the tune of 2 to 4 times in serum alkaline phosphatase, and this is because of the placental isoenzyme. A mild decrease in serum albumin levels due to hemodilution. Now, talking about acute fatty liver of pregnancy, it's an important, or rather one of the most frightening obstetric emergency with significant maternal and perinatal morbid mortality. It is characterized by microvesicular fatty infiltration of liver cells in the late second and third trimester of pregnancy, and it is an example of mitochondrial hepatopathy due to defect in the mitochondrial beta oxidation of fatty cells. So when we look at the clinical features, we know it's more common in primiparous, however it can occur in the multipara ladies as well. It is a disease of late pregnancy presenting with vomiting, abdominal pain, mostly in the right side, jaundice, polyuria and polydipsia. Patients suddenly complaining of बहुत प्यास लगने लगी and have to go to the washroom every now and then. Patients may become very ill with features of encephalopathy, hypoglycemia and ascites. मेरी patient तो पिछले हफ्ते ही आपके पास आई थी, she was all right and suddenly she is so ill. That's the kind of thing we may get. Liver function tests usually show mild to moderate increase in the aminotransferases with jaundice, which may be quite high, maybe above 10 milligram per dl, coagulopathy, renal failure, hyperuricemia, which could be marked. In pregnancy, usually it's below 6, but here it can go up to 10, 11, 12. Leukocytosis commonly observed, 20,000, 30,000. Now, ultrasound can show fatty infiltration of liver, very non-specific. Liver biopsy showing diffuse or perivenular microvesicular stenosis is the gold standard. However, it is not required to do so. It may be even dangerous in the face of coagulopathy. We have the Swansea diagnostic criteria for AFLP with symptoms of abdominal pain, vomiting, polyuria or polydipsia and encephalopathy. And the lab parameters of raised bilirubin, ALT, hypoglycemia, coagulopathy, deranged renal function tests, hyperuricemia, increased ammonia, leukocytosis, and of course the radiology and histology. Presence of any 6 out of the 14 criteria in late pregnancy without an alternative explanation clinches the diagnosis. We also have a CMC Valor criteria, which is much a simplified one. So, to manage this, serious obstetric complication, we need to have a multidisciplinary team with obstetricians, hepatologists, physician, intensivist, transfusion medicine, nephrologists, anesthetists, neonatologists, and so on. We have to continuously monitor them for hypoglycemia, prompt delivery after stabilization of the patient, irrespective of the gestational age. Cesarean section may usually be preferred because we have things in control. Although vaginal delivery may be attempted, it's not contraindicated. Coagulopathy needs to be addressed prior to delivery with adequate blood product replacement. Traumatic delivery and regional anesthesia should be avoided. And in fulminant liver failure, sometimes liver transplant may be the only answer. Only few years back, I remember one of our senior gynecologists had to airlift one of our medical patients, and she had a liver transplant in Delhi, maybe in one of the institutes where you're coming from. And the patient survived. We cannot forget our babies. So perinatal mortality remains high, and a child has to be monitored for features of fatty acid oxidation. And avoidance and early management of catabolic stresses is required. So we need to inform a neonatologist accordingly, and there may be recurrence in some of these patients. So coming to our next condition, that is preeclamptic liver dysfunction. We know that preeclampsia, that is a hypertension that occurs after 20 weeks of pregnancy, associated proteinuria with or without erythema. It has two stages. First is the abnormal placentation leading to placental hypoperfusion, and the second stage is the endothelial dysfunction leading to multisystemic involvement characterized by preeclampsia. So patient may be asymptomatic or present with abdominal pain, nausea, vomiting. Here I would just want to emphasize that presence of a liver dysfunction indicates that it is a severe involvement, severe preeclampsia, and it is time to deliver the patient, because that is ultimate treatment. Here again we have to take care that we have taken care of the lung maturity with betamethasone and dexamethasone, and neuroprotection if earlier than 32 weeks. Prothrombin time is usually normal except in patients of DIC. HELLP syndrome is considered as a severe form of preeclampsia, and here again we would need to deliver the patient. So control the BP, and if already 36, we expedite the delivery. Any thing of severe preeclampsia, we must deliver. We know parenteral magnesium is the mainstay of treatment to prevent and treat convulsions. Now HELLP syndrome, which is for hemolysis, elevated liver enzymes and low platelets, diagnosed by serum LDH more than 600 units per liter, characteristic peripheral smear, indirect hyperbilirubinemia, but not necessarily for presumptive diagnosis. Elevated liver enzymes, ALT would be more than 70 double, and platelets usually less than 1 lakh. So pathogenesis secondary to endothelial dysfunction and thrombotic microangiopathy. When it is associated with preeclampsia, the prognosis is better. Abdominal pain, nausea, vomiting with or without jaundice are usual symptoms. Majority of patients, they would present in the third trimester, but one-fourth can even present after delivery. And because of liver and the low platelet, ultrasound or CT of liver may show hemorrhages, subcapsular infarcts and hematoma. Severe thrombocytopenia portends poor prognosis and need for urgent delivery. And abnormally elevated prothrombin time signifies underlying DIC. So here we just mentioned that urgent delivery is needed. Most of the time platelets are not needed. And route of delivery, the obstetrician understands best. may be cesarean section or it may be vaginal, depending on the cervical position, the gestation, and so many other obstetric conditions. So complications, we know that maternal mortality can be as high as 1 to 15%, may be associated with serious maternal morbidities and complications like acute renal failure, hepatic infarct, hepatic hematoma, hepatic rupture, DIC, PPH, pulmonary edema, and rarely liver cell failure. Patients with renal failure need longer time to recover and will require prolonged dialysis. And most of the perinatal complications like asphyxia, respiratory distress are related to prematurity. So that brings me to the another pregnancy specific condition, the intrahepatic cholestasis of pregnancy. It is one of the most common disorders. It is characterized by maternal pruritus, increased serum bile acid concentration, typically resolving postpartum. The pruritus is most common in the palms and soles, worse at night, without presence of rashes. Other symptoms like nausea, vomiting, fatigue, right upper quadrant pale, dark urine, pale stools. They could be there. Clinical jaundice might be present in few patients up to 25%, but it is quite low to not usually less than 6 mg%. And total bile acids is the most specific marker, and the cutoff value of 19 micromole is now taken. Risk of fetal complications increases with severe cholestasis, increased serum bile, especially if it is 100 or more, we need to deliver urgently. Other liver functions may be mildly elevated. Etiology is not really understood. High levels of estrogen, conditions that lead to it. Also prevalent in women with low selenium and vitamin D. Women with multiple pregnancies, IVF treated. Older women and those with history of gallstones and hepatitis C infections and a family history. So implications for mother are not very much, except the patient is in great discomfort and we need to allay it. We need to frequent monitoring, so patient would have to visit her more frequently, and induction of labor may be needed. Cesarean sections are higher and risk of PPH may be there. But we are more concerned as obstetricians about the perinatal outcome, because there is significantly increased risk of both spontaneous and iatrogenic preterm births, meconium stain liquor, and neonatal unit admission, and also stillbirth rate with an adjusted odds of 2.5. And the unfortunate part is there is no effective treatment known till now. Ursodeoxycholic acid improves biochemical parameters and reduces pruritus. Rifampicin may be added in very resistant cases of itching. Antihistamines can be added. Emollients can also allay the itching to some extent. None of the existing antenatal tests either predict or reduce the risk of adverse perinatal outcome, and a discussion should take place with women regarding induction of labor as she nears the term, and earlier if the biochemistry is severe. That means bile acids more than 40, definitely nearing 100. Timing of delivery should depend on balancing the risk of fetal death and prematurity. Hepatitis B is very rampant in our country, and variously depending on where you're working. In my hospital, I think pregnant ladies, last year census said it's about 6%. Hepatic flares or acute liver failure occurs only rarely in pregnant women with chronic hepatitis B. HPV DNA testing should be done at booking and again at 28 weeks. And consider treatment with tenofovir in active disease of cirrhosis, DNA more than 2 lakhs, HBE antigen positive at 28 weeks. Caesarean section is reserved for usual obstetric indications, and HBsAg positive status itself is not an indication. And we should ensure that the neonate gets immunization passive by HBIg 0.5 ml, preferably within first 12 hours, and active 3 doses day 0, day 1 month and 6 months. If the day 0 was not immediately available, up to 7 days. HCV, all our societies, they recommend universal screening for HCV in the antenatal period. Directly acting antivirals in pregnancy and pre-pregnancy and interpregnancy, so that when she enters properly, she would be cured of her disease. Now we also often get chronic liver disease with Porter Harbor. Not often but rarely, but we do get, and I remember 3 cases very specifically. If beforehand we have endoscopic ligation of bands, beta blockers, during delivery, whether be it by cesarean section or vaginal delivery, there is a risk of bleeding from the varices. And for acute bleeding, we can have IV octreotide, somatostatin, balloon tamponade, endoscopic banding tips, whatever. But I know this is not our, but we have, therefore we need a team. And coincidental acute disorders, we know viral hepatitis have beautifully enumerated all of them. For us, very important HBE, because here the bilirubin can go really high and it can be a prolonged hepatitis infection. Then some drugs that we are routinely using is progesterone in pregnancy, which can again increase the serum, can cause cholestatic-like picture. And just my last slide maybe, we have to know about our contraceptive choices. Those combined OCPs, they can cause increase the cholestasis, the combined OCPs, so we have to be this thing, others are mostly safe. So thank you everyone for the patience.
Thank you, ma'am, for your deliberation. I would like to request you to please be seated on the dais itself. May I have the honor to invite our next speaker for the session to kindly come up on the dais. Dr. Jayanta Kumar Ghosh. Dr. Jain is consultant gastroenterologist in Ranchi. He has more than 45 publications in different national and international journals. His area of special interest lies in endoscopic treatment of bleeding ulcers and varices, ERCP, PEG placements, capsule endoscopy, etc. His topic for discussion is liver diseases in pregnancy. May I request him to please begin with this topic.
Respected chairperson, respected seniors and my dear colleagues, at the onset I'd like to thank Dr. Vijay Shankar to give me this opportunity. Thanks a lot. Ma'am has already discussed a lot of things, so my job is a little bit easier. So today we will discuss liver diseases in pregnancy, and what ma'am has already told, a few slides, what I think as a gastroenterologist we should know. Now, actually what happens in pregnancy that sometimes the normal physiologic and the biochemical changes that happens in pregnancy mimic like chronic liver disease. Why? Because there is increased circulating plasma volume. The heart rate is increased. The cardiac output is increased. But what happens that most of this cardiac output, it goes to the placenta. It doesn't go to the liver. So what happens that liver has almost the same blood volume, blood circulating volume. So it results in a hyperdynamic state, which is almost similar like a decompensated cirrhosis, and it will lead to your insignificant esophageal varices. Sometimes palmar erythema can be seen in normal patients who do not have any underlying chronic liver disease, but during pregnancy it can be seen. Spider angiomas can also be seen. Pregnancy leads to decreased gallbladder motility, which leads to more GB stone incidences. Now, I have already discussed that since there is, as you can see, that there is the splanchnic vasodilatation occurs, blood volume increases, and ultimately there may be sometimes the ascites may increase in CLD patients. With CLD patients, that's why they have increased chance of variceal bleeding if they have already underlying CLD. Sometimes hepatic encephalopathy can be exacerbated in CLD patients with pregnancy. Now, already Madam has discussed the liver diseases in pregnancy can be classified into 3 categories. Number 1 is some diseases which are very unique to pregnancy. As Madam has already discussed, those are the intrahepatic cholestasis, the preeclampsia, eclampsia, HELLP syndrome, acute fatty liver of pregnancy. Few diseases which need special treatment during pregnancy, and few diseases which are common in general population, but they should be addressed well to the pregnant woman during pregnancy. Now, so what is the current guidance statement. The statement is that in a pregnant lady, if the SGOT, SGPT or bilirubin or bile acid are elevated, then she needs further investigation. So if SGOT, SGPT or bilirubin or bile acid is increased, bile acid we generally don't do in our first visit. So if SGOT, SGPT and bilirubin are elevated, then go for further investigation. Now, this is the chart for evaluation of abnormal liver tests in pregnancy. If it is a cholestatic pattern, if you think that there is, GGT is increased, alkaline phosphate is very much increased, because some alkaline phosphate comes from the placental origin also. And if it is a cholestatic direct type of bilirubin, then go for ultrasound. Go for ultrasound and consider other etiologies also, like drug-induced injury, PBC, PSC, etc. And you send the specific other tests to diagnose what is the cause of this cholestatic pattern. If there is hepatocellular type of pattern, then you go for the viral hepatitis, autoimmune hepatitis, drug-induced hepatitis, or NAFLD or NASH, Wilson disease, other viral markers you have to send. Autoimmune hepatitis, for Wilson disease you have to send ceruloplasmin. These are the things. And for pregnancy specific diseases, as already madam has discussed, so you have to send especially the bile acid level. Now bile acid level, if it is more than 10, or ma'am told that it is more than 19, in some guidelines it is written as ASLD guidelines, more than 10, then it is significant, and more than 100 it is more significant. Now coming to another interesting topic, that is abdominal imaging during pregnancy. Sometimes we gastroenterologists met that what we have to do, whether ERCP should be done or not, how much exposure has to be given. So the guideline says that CT abdomen or pelvis with no contrast can be done, but generally we avoid doing CT scan during pregnancy. But the guideline says that it can be done. Point number 3, abdominal CT without contrast is generally safe in pregnancy, but the exposure should be less than 50 microgray cumulative. That means in the total, it should be less than 50. So if it is very necessary, then you can go for CT, because you have the evidence. So nobody can challenge you. It is in the ASLD guidelines that CT scan may be done without contrast. MRI or MRCP without gadolinium is preferred over CT imaging. Gadolinium is, however, it is contraindicated in pregnancy. So MRCP, in which most of the MRCP, no dye is required, so MRCP can be done. MRI without gadolinium can also be done, but gadolinium is contraindicated in pregnancy. Abdominal ultrasound without contrast is preferred imaging modality. Here we have very limited data about the Doppler, that better not to use Doppler erratically, because if you have to talk with the radiologist, that it should be a very limited type of Doppler. Now, use of iodinated contrast is recommended only if it is very essential. There are insufficient data to recommend use of elastography during, so fibroscan, which nowadays we do rampant here and there. So during pregnancy, we do not have sufficient data to recommend fibroscan during pregnancy. Breastfeeding is safer after iodinated or gadolinium contrast if used at all. Now, chronic hepatitis B during pregnancy and lactation. All pregnant women should be tested for HbSAg. Women newly identified HbSAg positive should be linked with a hepatologist, a gastroenterologist, or a treating physician. HbSAg positive pregnant women should be informed of the increased risk of mother-to-child transmission with invasive pregnancy procedures like amniocentesis. These are the procedures where there is high risk of transmission of hepatitis B from mother to child. Now, although the neonatal vaccination along with the your HBIG along with your vaccine is very effective if it is given within 12 hours or as early as possible after the birth of the newborn. But sometimes what happens, that if the viral load is more than 2 lakh IU per ml during the third trimester of pregnancy, then there is certain chance that the baby or the fetus may get infected with HBV hepatitis B. So, all pregnant women, if they have a very low viral level throughout the pregnancy period, you have to do a HBV DNA level at 28 weeks. And if it is more than 2 lakh per IU per ml, then you have to give antiviral not for mother. It is to prevent from mother to child transmission. So all pregnant lady, pregnant ladies, they have two indications for antiviral treatment. One for herself, if she has cirrhosis or if she has fitting into criteria for hepatitis B treatment, then she has to take. There is no doubt in this. But any patient who is incidentally detected and at 28 weeks, if you found that it is more than 2 lakh IU per ml, then you have to start the antiviral therapy. And if it has to be given at least 3 months postpartum, and after stopping the therapy, then you have to very closely monitor the mother for flare up of the hepatitis B. Now, which antiviral is preferred? Now we have enough data that tenofovir desoprovil is the preferred one. Now, latest tenofovir alafenamide, which is available in market with 25 microgram. Now, according to the guideline, it is still not recommended because of paucity of data. But in morning, Anil Arora sir have told that you can use this, but we do not have that recommendation. So till date, the recommendation is tenofovir desoprovil fumarate 300 milligram is the preferred antiviral. And monitoring of ALT and HBV DNA for 6 months postpartum or after cessation of antivirals is recommended. Now remember, breastfeeding is not contraindicated. This is very important. Breastfeeding is not contraindicated even in women who continue on antiviral therapy. Previously, it was thought that breastfeeding is not contraindicated to hepatitis B positive mothers, but mothers who are taking antiviral, their breastfeeding may be stopped. But now the guideline says that you should not stop breastfeeding even if the mother is taking antiviral. Hepatitis C, ma'am has already told that all pregnant women should be tested for hepatitis C during pregnancy, if not done earlier. If pregnancy is planned, then in hepatitis C patients, then at least all the antiviral or ribavirin, either they have to be given 1 year before conception, planning of conception, or after delivery it has to be given. And then similarly, amniocentesis and these things can lead to more transmission of hepatitis C from mother to child. Wilson disease, it is also common in the young population. So zinc is safe in pregnancy. Chelating agent should be continued during pregnancy if already started, but newer chelating agents better to avoid during pregnancy. Zinc is the most safe. Breastfeeding is associated with infant risk, as all Wilson disease drugs are excreted in breast milk, and there is risk for copper deficiency in infant also. Autoimmune hepatitis. Now, in autoimmune hepatitis, azathioprine and 6-markup-to-purine is recommended. Prednisolone and budesonide are considered low risk in pregnancy and lactation, hence can be given. But mycophenolate products are contraindicated during pregnancy and lactation also. Liver test during monitoring during each trimester is suggested, and breastfeeding, however, it is not contraindicated if mycophenolate is not given. PBC and PSC. PBC, UTCA is safe in pregnancy and lactation also for PBC, although no data support a therapeutic benefit for PSC. Obeticholic acid, which is very common nowadays in use, cannot be recommended in pregnancy or lactation in women with PBC due to lack of safety profile. Or safety data we do not have. Now remember that clinically significant or non-responding pruritus, you may sometimes need cholestyramine, rifampicin, SAMe, antihistamines, but cholestyramine sometimes lead to vitamin K deficiency, which can lead to sometimes intraventricular or intracranial hemorrhages in the newborn or in the fetus. So PT monitoring is required, and if needed, vitamin K injection should be given. Non-alcoholic fatty liver disease, I am not going into detail, but evaluation and all the similar counseling which we do in the normal population, it should be done. Breastfeeding is encouraged in non-alcoholic fatty liver disease, and longer duration of lactation is associated with lower rates of future NAFLD among the offsprings. So here breastfeeding should be encouraged. Now, alcohol associated liver diseases, pregnant women should be screened for alcohol if you are suspecting, and then refer for management. And these two are the special condition which needs in pregnancy, like hepatocellular adenoma and hepatic hemangioma and FNH. Not very common condition, but if it is more than 5 centimeter, then it needs some treatment. If it is less than 5 centimeter, then you can wait. Now I am not going into these things. Already ma'am has discussed. Now pregnancy in patient with cirrhosis, it is very important. Varicose screening within one year prior to conception is very important in CLD patients. If there is if it is done and if there is no varix, then no treatment is indicated. If there are small varix, then during pregnancy you can use non-selective beta blocker, or if there is medium or large varices, then better you do EVL, prophylactic EVL, or a non-selective beta blocker are also indicated here. But if the endoscopy was not done prior to pregnancy, then it should be done in the second trimester of pregnancy. Now here one thing I would like to mention, that early pressing should be avoided in acute variceal hemorrhage in pregnant ladies, because it will lead to uterine contraction and it will lead to less blood flow, less uterine blood flow and less fetal blood flow. Mode of delivery has to be decided by the obstetric according to the obstetrician, and already these things are already discussed by madam. I am not going into detail. Hyperemesis gravidarum, it presents with dehydration, and supportive care is the most important thing. So with this, I will complete my slides, and then if you have any question, we answer.
Thank you, sir, for your deliberation. We now hereby are open for discussions on the topic, and we also invite queries from our delegates sitting off the dais. We request our chairpersons on the dais to set about the discussion.
Thank you very much. Both the speakers have done a brilliant job, Dr. Meena Samant and Dr. Jayanto Ghosh. Of course, Dr. Meena Samant, she's thrown light on how liver matters to us from the obstetrician's perspective. But definitely liver matters to us, because a lot of, as she highlighted, the obstetric conditions where there is a liver problem, but majority of them are problematic for the fetus rather than for the mother, like intrahepatic cholestasis of pregnancy especially. And Dr. Ghosh has thrown light on in general all the liver disorders in pregnancy. Now as I would like to say something that especially in the Indian subcontinent, the intrahepatic cholestasis is really the incidence is quite high, especially in the Indian subcontinent. And otherwise, and as we all know that it recurs in pregnancy, there is a genetic predisposition. And now with the increasing the use of ART pregnancies that which are conceived through ART, and we are giving all the hormones for support. So that also increases the incidence of intrahepatic cholestasis. A lot of us, like Dr. Himanshu Roy, would not disagree that we are facing a lot of coming across a lot of patients who are developing intrahepatic cholestasis, and sometimes it is difficult to manage. So one question I would like to ask any of the speakers, unless my co-chairpersons would like to say something before. Okay. So like if there is a patient who has intrahepatic cholestasis, she's around, say 32, 33 weeks. And her ALT is quite high. Now, we started her on ursodeoxycholic acid like, most of us would do. She has been relieved of the pruritus. But I was quite surprised that, her ALT has just not responded. It's just stuck, at around 300 or so. So I'm just wondering whether, could it be due to some pre-existing liver disorder but she has presented, typically with pruritus, and as one would suspect that she has intrahepatic cholestasis. So what would you say in such a condition? And I have put her on ursodeoxycholic acid. She has been on it for 1 month.
Thank you, ma'am. It's a very important question. So, what I think that in this case, you have to rule out other causes of underlying any CLD, because sometimes what happens that she may have CLD but which was undetected. But right now, due to stressful condition and other pregnancy related problems, what happens that the CLD might have been flared up. So you should continue with ursodeoxycholic acid, no harm in that, but evaluate for the other causes of, especially the autoimmune markers and these things.
Generally what happens that in intrahepatic cholestasis, we don't like the pregnancy to go beyond 37, 38 weeks. But if if it is not a case of intrahepatic cholestasis, and one thing I forgot, actually her bile acids are normal. So in such a situation, do you think can I just carry on with the pregnancy up to 40 weeks, or should I induce her earlier or do a cesarean section? Because as I said, ALT is not declining at all.
Dose can be increased. Stasis as such is based on, when we did not have bile acids, we were relying on the clinical feature of itching and SGPT as a surrogate marker. But now that bile acids are easily and readily available, we would rather go for bile acids.
But she's typically presenting with itching over her palms and soles, as it would happen in a case of...
for those, that itching and still it is there.
Yeah, that's what. She has been on ursodeoxycholic acid. She has been relieved a bit, from pruritus, but not completely.
Actually, what happens is that patient gets relieved symptomatically, but enzymes and SGPT is still high. So we are worried about that. What can it lead to, especially when it is the case of early pregnancy. So in these cases, the only thing that we can give is ursodeoxycholic acid, and we do give that restriction also. I heard Dr. Sood about telling our children that before that restriction will be there. But we do ask these patients to avoid salt and oily and spicy food. But what else can be done? Because usually we do evaluate these patients even before pregnancy. It's not that we directly go.
I think you also need to check if she is on some,
and
some
ultrasound finding
progesterones.
also, there is no other feature. So in these cases when SGPT is rising, so sometimes, especially in cases of IVF, when we are giving high dose estrogen, and it might be one of the reasons, but we are stuck because we cannot withdraw also directly.
I think even the guidelines have somewhat changed. They have become more liberal now. That 10 units has gone to 19, 20. I was saying this is the latest one. RCOG and American College, both they have gone to 19 international units. So because we were thinking we were reacting, at the risk of prematurity also, and doing a lot of cesarean. So I think studies over the years have shown that it's not 10, and just jumping and doing a cesarean may not be that effective. And also, as we've already said, that ursodeoxycholic acid will give only a symptomatic relief. And as such, if there is some this thing, bile acids are high, then we have to plan the delivery, otherwise we can.
I would like to make 2 points. First, regarding your question. So the level of SGPT or SGOT per se does not matter. They just signify that hepatocytes are getting damaged and enzymes are coming out into the blood. So we don't change the levels per se. If the patient is proceeding to liver failure, we have other markers. PTINR will be getting deranged. The clinical parameters will be getting deranged. If that is happening, and bile acid is more than 100 or more than 40,
you decide to terminate the pregnancy or early pregnancy. If all parameters are normal, even if the SGPT is 1000, that is no criteria for terminating the pregnancy. So 50 or 300 or 400 don't change the target of SGPT. We have to see the patient clinically. So we cannot terminate the pregnancy just on the basis of one SGPT level. It does not matter. That is the first point. And second point regarding AFLP, as ma'am told, is quite rare condition but very lethal. One point I would like to give as a message for the audience, like CMC Vellore has one of the largest case series for FLP. Before the year 2000, the mortality rate in our hospital in CMC was around 80%, 80 to 90% for FLP patients. And now it is less than 5%. So what has changed in last 20 years? So one recent change what has happened is that all the FLP patients have deranged coagulation profile, have very low platelets, very deranged INR, and were getting blood products right and left. They were getting so many blood products and hundreds of units of platelets and FFP. So what changed? That now FFP is being transfused prior to transfusing platelets, like similar to HUS and TTP, with the precondition that these patients are very low in ADAMTS13 enzyme levels and very high level of vulnerable factors, which cause the derangement of the end organ due to clotting of the coagulation factors and the clotting happening in the microcirculation. So when we give fresh frozen plasma before platelets, what happens that ADAMTS13 gets replaced and the platelet plugs don't form and the patients survive. So just one take-home message, that even whenever we are giving platelets, we have to give FFP prior to it in the ratio of 2:1. Like if there is 2 units of platelets are planned, we give 1 unit of FFP prior to giving platelets. Just this one simple measure has reduced the mortality of FLP from 80% to less than 5%. So this is a very important take-home message for us Bihar physicians, everybody, and gynecologists, to the ratio of FFP to platelet, and always give FFP prior to platelets. That is one important message.
Excuse me, I would like to add to ma'am's question. Ma'am, in that case, ma'am, the dose that you prescribed for was also the oxycodone acid was 300 milligrams. But the latest guideline now they have stated that we can give up to 500 milligrams 3 times a day. And if it is still resistant, we can add rifampicin. That is one part. And regarding delivery, if the bile, that is what I agree. The sir has already said that if the bile acid is normal, we can carry the pregnancy. SGPT is just a symptom. It is the pruritus that we will present, but it will never be toxic to the babies.
Basically, it was, to incite a discussion, when you come across a case like this, where in spite of UDCA, LFT is not going down. And we as obstetricians, we are more focused towards ICP, and so that's why it was the whole idea was to trigger a discussion and get something out of it, as my co-chairperson has just highlighted. So I think we can close this session, and thank you to Dr. Vijay Shankar for having given this opportunity to chair this prestigious session.
Thank you everyone for your involvement. We would like to request our chairpersons to present the memento of appreciation to our speakers and join us for a short photography session. Thank you everyone for your honorable presence. Moving on to our last session of this conference, which is a gastroenterology test,
Moving on to our last session of this conference, which is a gastroenterology quiz, I would like to invite all our quiz enthusiasts to please come forward in the rows. May I have the honor to invite our chairperson for the session, Dr. Ashish Kumar Jha, consultant gastroenterologist at IGMS Patna, Dr. Vijay Shankar, gastroenterologist at Patna, Dr. Pankaj Kumar, gastroenterologist at Big Apollo Spectra Hospital, Patna, Dr. Amaya Ranjan, consultant gastroenterologist at PMH Jamshedpur. May I request our quiz master, Dr. Avanish Kumar, a consultant gastroenterologist at Reuben Hospital, Patna, to come up on the dais.
24 questions, and for each question you will have 30 seconds to analyze and answer. So is everyone ready? Shall we start now, sir?
Ask the aspirant to come forward.
Yes.
Ask the aspirant to come forward.
Anyone, please everyone come forward. Don't sit behind.
Listen to the instruction.
So, look at this sheet, and here you have to fill the details and then answer after each question.
मोबाइल बंद कर today's examination style is
They won't get time to analyze the mobile. Question will
So remember, time is only 30 seconds for each question. This is your first question. अपने आप क्वेश्चन आगे बढ़ा नहीं बढ़ा ना क्वेश्चन नहीं बढ़ा इसलिए बोल रहा नहीं बढ़ा So is your second question?
same question. Go ahead.
Second question. This one is second one.
थर्ड मिस हो गया
बोलते जाओ डॉक्टर अपनी
वैसे थोड़ा सा प्रॉब्लम
मिक्सर पहला का तीन तो बहुत भारी कुंटल लोग गिन
Hope all the participants have received this answer sheet. Do I have any more? No.
Missing. One is missing.
Okay, only 20 questions.
24 questions are there. Total 24.
Where are those four questions? Do we have those 4 questions?
Yes, sir. We have 24 questions total.
Okay. So it's written 20. 4 more questions. Okay.
this is the last question, and this concludes our page master session. So we are now moving to the right answers. Please join. I will say what are the right answers, and you will match the questions.
And best of luck.
बाद में कलेक्ट किया जाएगा
Question here. Dr. Sidhali, Dr. Rahul Arya,
For second question, answer is option number 4, glycogen storage type 3. For third question, answer is option number 1, angiography. For question number 4, answer is option number 3, erythromycin. So for fifth question, about physiological changes in pregnancy includes all except, answer is increased serum aminotransferases. Question number 6, which of the following is a risk factor for pigment gallstone? Answer is ileal disease. Question number 7, which of the following condition has the lowest risk of colorectal carcinoma? Answer is Cowden syndrome. Which of the following is recommended fluid for resuscitation in acute pancreatitis? The question number 8, and answer is lactated Ringer's solution. All of the following conditions can cause chylositis except nephrotic syndrome. Question number 10, which of the following test is reliable for diagnosis of H. pylori in patients on PPI? The answer is H. pylori serology. True about daily salt consumption for patients with liver cirrhosis and ascites. Answer is 5 grams salt per day. In all about one situation, cirrhotic patients should get a human albumin infusion. Answer is severe hypoalbuminemia. In patients with acute severe ulcerative colitis on IV steroids, when should we consider rescue therapy? The duration is after 3 days. Failed response at 3 days. False statement about abdominal tuberculosis is that concomitant pulmonary tuberculosis is rare. This is a false statement. Antiviral therapy is recommended for HBV infection without considering liver enzymes, HBeAg status, or HBV DNA level in all situations except pregnancy with jaundice. Which of the following drugs is not indicated for treatment of constipation? And it is acosciamide. Which of the following is the most common cause of acute liver failure in India? Answer is hepatitis E virus. Which of the following NSAIDs has the lowest risk of GI toxicity? And answer is ibuprofen. Which of the following PPI should be avoided in patients on clopidogrel? And the answer is esomeprazole. Which of the following extraintestinal manifestations of IBD is independent of intestinal activity? The answer is alopecia areata. What does watermelon stomach on endoscopy indicate? It is gastric intravascular ectasia. False statement about osmotic diarrhea is it worsens with fasting. This is the false statement. When an infection is acquired by adult, which of the following Virus has maximum risk of chronic hepatitis. Answer is hepatitis C virus. High serum albumin gradient, ascites albumin gradient indicates portal hypertension. So, we hope question number 19 was missing. We are hoping to get our quiz master soon.
So we had our quiz session under Dr. Avnish, the quiz master. In the meantime, we would like to calculate the answers and rights and wrong, and we will decide about the winners. And at the last session, that is valedictory and prize distribution ceremony at the last. In the meantime, we would like to have the best 3 papers to be presented on stage, and we would like to call upon the 3 persons who have been informed about not only uploading their documents but also to be present at the dais one by one. So I'd like to invite all 3 of them to be there at the podium at the dais, and one by one we will be asking them to present their case. Thank you.
Total of 17 posters were presented, and independent externals who came, they were assessed all the 17 posters, and we have selected 3. The first is by Dr. Siddhali Vadaskar, which is about, it is not the rank, it is just the 3 of them have been selected, and then the rank will be told from the stage in some time once they present the oral papers. So liver biopsy in patients with gallstone disease and concomitant NAFLD undergoing cholecystectomy. So this was the first one. The second, prevalence and risk factors of lymphatic dysfunction in cirrhosis patients with refractory ascites by Dr. Rahul Arya, who is the SR Gastro at AIIMS Patna. And the third one is clinical profile and outcome of patients with upper GI bleeding presenting to emergency department by Dr. Jainul Abadin from AIIMS Patna. These 3 have to present as oral papers.
Good afternoon everyone. So my topic is clinical profile and outcome of upper GI bleeding patients presenting to emergency department in a tertiary care center. So we all know that upper GI bleed is one of the most common medical emergencies that we see routinely in emergency department. Although the incidence has been decreased, but the mortality due to upper GI bleed has been increasing, and it has not decreased, it is increasing trend. So upper GI bleed is broadly divided into varicial and non-varicial sources. Varicial sources we include the gastroesophageal varices and portal hypertension gastropathy, whereas non-varicial sources include erosive gastritis, peptic ulcers, Malmö-Weiss syndrome, tumors and vascular lesions such as Dielfoys lesions. And there are different, there are regional differences in the etiological spectrum of upper GI bleed. So my aim of the study is to study the possible etiology, risk factor and outcome of patients with upper GI bleed in emergency department. And my objectives were to determine the cause of upper GI bleed in emergency department using endoscopy, and to measure its severity and outcome at 30 days will be recorded, and to assess the poor prognostic markers for it. My study design is observational study and hospital based. All patients greater than 15 years presenting with symptoms of upper GI bleed were included under my study. And exclusion criteria were patients with traumatic upper GI bleed and patients who will not give consent for the study. So my study procedure was patient presenting to ER with features suggestive of upper GI bleed. Their demographic profile and clinical profile and risk factors were recorded, and their clinical examinations were recorded, and laboratory investigations like CBC, LFT and KFT were sent, and ultrasound whole abdomen was also done, and treatment strategies in ER were recorded, and number of blood transfusions were also recorded, and patient was sent for endoscopy, and final treatment plan was also recorded, and outcome at 30 days will also be recorded. So total number of patients I got in this 1 month are 25, out of which 19 patients I was able to do endoscopy. In that 12 patients had a varicial source of bleeding, whereas 7 had non-varicial source of bleeding, Among the non-varicose source, four of them have peptic ulcers, one of them had dilphos lesion, and two of them were having a normal endoscopy. The patients were on warfarin and antiplatelets, so it might be due to that. And 3 patients were referred to other centers, and 3 patients unfortunately died in emergency department. So among the males, like among the participants, I have got the 84% of them were males, and only 16% of them were female. Age less than 40 years were 9, and age greater than 40 years were 64. Mean age was around 43 years. And the patients with like chief complaint was melena in 64% of the patient, and hematemesis was seen in around 44% of the patient. Bleeding per rectum, we usually ignore it because we think it has a like lower GI bleed, but upper GI bleed, severe upper GI bleed can also present as upper GI bleed. It can have upper GI source of bleeding. So bleeding per rectum, one patient of bleeding per rectum had lower, upper GI source of bleeding. And alcoholics, 70% of patients of upper GI bleed were alcoholic, and 5.6% of my patients were hepatitis related, and 16.7% was due to NAFLD. So mean age of the patients with upper GI bleed was around 43.2. Mean HP of the patients was 7.8 grams per deciliter, and mean platelet count was around 1,46,000. So 12 patients in whom endoscopic profile suggested varicose source. USG shows that one patient had Budd-Chiari syndrome, and one patient had hepatocellular carcinoma, and other all showed the features suggestive of CLD. So nearly 52% of the patient had ascites, and 1:to creatinine ratio was greater than 20:1 in 80% of the patient. It suggests that 1:to creatinine greater than 20:1 had high sensitivity in upper GI bleed in detecting upper GI bleed, and among 76% had hepatomegaly, and splenomegaly was seen in around 50% patients. Sorry, 20% patients. So out of the 25 patients, 15 patients required blood transfusion, which itself tells that upper GI bleed is one of the most common and most severe medical emergency that we need to intervene in early hours. 12 patients were having varicose source of upper GI bleed. One patient was on anticoagulant. We have treated with the help of vitamin K and fresh frozen plasma. And one patient had peptic ulcer disease, and one patient had dilphos lesion. So out of the 25 patients, 4 patients present to ER were in shock, and out of which 2 patients cannot be revived. All the 3 mortalities were attributed clinically to varicose source of bleeding. Itself indicates that varicose source have high risk of mortality in ER. So on endoscopy, out of 12 people having varicose source of bleeding, 6 people were having large esophageal varices, and out of the 19% undergone endoscopy, 11 were treated conservatively. 4 patients were underwent endoscopic band ligation, and 3 were treated using only proton pump inhibitors, and 1 person has undergone argon proton coagulation therapy. So my conclusion is varicose bleeding is one of the most common of upper GI bleeding in emergency department, and fatality rate among the varicose sources was very high. And poor outcome indicators in my study were hematemesis, patients with low BP, and increasing age of the patient. 1:to creatinine greater than 20:1 was nearly 80% sensitive in identifying upper GI bleed. And mean Blatchford scoring, which help in guiding the intervention, what intervention we have to do, was around 10.8, and it indicates that most patients presenting to the emergency department required active intervention.
So we are not going to ask any question because you already asked. Some suggestions, like when we are presenting our data, then there should not be any future trends like I will be recorded, I will be, so we did kind of, I was हो जाएगा ना, ये तो स्टडी हो गया तो. So it's in plan. It's a plan. When you are writing plan, then it will be. When already you collected data, you made conclusion, then it means now it's better. First, one thing. Second thing, whenever you are mentioning mean, always try to put standard deviation or at least in the range or something. Isolated mean, always remember this one. And some should, like APC, not argon proton, it's argon plasma population, like low BP is a vague term, hypotension, you can say hypotension. So, but overall very good. Thank you.
myself Dr. Rahul. I am DN resident in All India Institute of Medical Sciences, Patna. So this is my original work, my thesis work. I did this under Professor Dr. Ramesh Kumar, who is an additional professor and head. The title of my thesis is Prevalence and Risk Factors of Lymphatic Dysfunction in Cirrhotic Patients with Refractory Systems. So just a little background, as we know that liver is the largest lymph generating organ of the human body. Around 25 to 30 or 50% of lymph that passes through thoracic duct is produced by liver. And the role of hepatic lymphatic system is to regulate fluid homeostasis by absorbing excess interstitial fluid and transporting it back to the bloodstream. During early stages of cirrhosis, there is compensatory expansion in hepatic lymphatic system that prevents formation of ascites. In advanced stages of cirrhosis, this compensatory mechanism becomes overwhelmed, leading to formation and worsening of ascites. And refractory ascites is defined as ascites that could not be mobilized because of lack of response to maximum dose of diuretic treatment or because patient developed complications that precluded the use of diuretics. So, whether the lymphatic dysfunctions are associated with refractoriness of ascites in advanced cirrhosis is not known. So, this study was conducted with the aim to determine the prevalence of lymphatic dysfunction using surrogate markers in cirrhotic patients with refractory ascites. So, there is no defined guidelines to how to diagnose lymphatic dysfunction. So, we have used surrogate markers for diagnosis of lymphatic dysfunction. And these markers are, first is clinical. Clinical is presence of peripheral lymphedema, which is evident by physical examination, which includes leg edema, usually PT, Uday orange skin, and a positive stemmer sign. And presence of chylous ascites, which is milky white ascites with elevated triglycerides level of more than 110 mg per deciliter, and presence of endoscopic features consistent with intestinal lymphangiectasia, which includes edematous mucosa with scattered white spots, white villi, and chyle-like substances covering the mucosa on endoscopy, and or intestinal lymphangiectasia on duodenal biopsy. So this is the patient who presents, we usually see commonly in patients with cirrhosis who have peripheral lymphedema. This is different from regular lymphedema, as this lymphedema is associated with typical skin changes like Uday orange skin and a positive stemmer sign. And these are the typical intestinal lymphangiectasias. Lymphangiectasias are whitish swollen villi in duodenum, suggestive of intestinal lymphangiectasia. On immunohistochemistry, we can see markedly dilated vessels in the lamina, which show strong D240 positivity indicating dilated lymphatics. And chylous ascites, as I have told, it is defined as milky white fluid with a triglyceride level of more than 110 mg per deciliter. So aim of this study was to determine the prevalence, risk factors, and clinical associations of lymphatic dysfunction in patients with cirrhosis of liver. The primary objective was to estimate the prevalence of patients with lymphatic dysfunction using surrogate markers. I have told we have used 3 surrogate markers, which include peripheral lymphedema, intestinal lymphangiectasia, and chylous ascites in patients with liver cirrhosis and refractory ascites. The secondary objectives were to determine the risk factors of lymphatic dysfunction in such patients by comparing to the relevant parameters between patients with or without lymphatic dysfunction. And second was to determine the clinical associations of this lymphatic dysfunction with other complications of cirrhosis. This was a hospital-based study conducted in the Department of Gastroenterology, AIIMS Patna from 1st August 2021 to 1st June 2023. Inclusion criteria include all the adult patients with cirrhosis and refractory ascites presenting to Department of Gastroenterology, AIIMS Patna. Exclusion criteria include patients who are hemodynamically unstable, patients with advanced hepatic encephalopathy, presence of GI bleed, patients with cancer or tuberculosis, post-operative or post-radiotherapy patients, and patients with congestive heart failure. So I skip the statistical analysis part. So on results, the baseline characteristic of our study cohort, the mean age was around 49 years, plus minus 13.1. Alcohol was the most common etiology of cirrhosis, and median duration of ascites was 5 months. Most common comorbidity was diabetes, which is found in around 17.4% of patients. So these were the baseline parameters, lab parameters of our study cohort. Coming to the results, when we found that around 52 patients out of total 155 patients have peripheral lymphedema, and intestinal lymphangiectasia was present in 42 patients, and cholelithitis was found only in 2 patients. And overall, of these surrogate markers of lymphatic dysfunction, around 44.5% patients have evidence of lymphatic dysfunction. So this is the same slide showing the. When we compared the patients of lymphatic dysfunction without patients without lymphatic dysfunction, we found that most common etiology of cirrhosis in patients with lymphatic dysfunction was NASH, and mean duration of refractory ascites was higher in patients with lymphatic dysfunction, which is 5 months, and the p-value is statistically significant. Similarly, the MELD score and child score were also statistically higher in patients with lymphatic dysfunction as compared to patients without lymphatic dysfunction. And patient with lymphatic dysfunction has more cellulitis as compared to patient without lymphatic dysfunction. Coming to the lab parameters, patients with lymphatic dysfunction have a more severe hypoproteinemia. 29 patients in the lymphatic dysfunction group compared to 13%, and this was statistically significant. Similarly, sodium was slightly lower in patients with lymphatic dysfunction, which was also statistically significant. Patients with lymphatic dysfunction has more severe lymphopenia and combined lymphocytopenia and hypoproteinemia. Triglyceride levels were also lower, but were not statistically significant. Coming to the independent association of lymphatic dysfunction on multivariate analysis, we found that 3 parameters which came out to be significant, which was obesity, lymphopenia, and hypoproteinemia, with the odds ratio of 4.2, 6.2, and 3.7 respectively. Coming to, we did separate analysis on patients who had lymphedema, and we found that the mean age was slightly higher in patients with peripheral lymphedema as compared to without lymphedema, and patients with peripheral lymphedema had a higher MELD score and a higher child score as compared to without peripheral lymphedema. Similarly, lab parameters, patients with peripheral lymphedema had a higher hypoproteinemia, lymphopenia, and intestinal lymphangiectasia and biopsy, and 2 patients out of the cohort has cholelithitis in patients with peripheral lymphedema. Coming to discussion. So after analyzing 155 patients of cirrhosis, features of overt lymphatic dysfunction were noted in 69, around 44.5% patients, including peripheral lymphedema, intestinal lymphangiectasia, and cholelithitis. Patient with lymphatic dysfunction had a higher mean age, and most common etiology was NASH that I have already discussed, and had a higher number of obese patients and
Dr.
higher
Rahul?
mean duration of.
Dr. Rahul,
Yes,
please come to the conclusion because it's highly useful.
yes, sir. I am just reading. This is the last slide. Patient with overt lymphatic dysfunction had a more severe hypoproteinemia, more severe lymphopenia, and more severe combined lymphopenia and hypoproteinemia. So I combined the discussion and conclusion parts.
One point for all the PGs present here, they may get confused. How did you differentiate between lymphedema versus just normal edema which every cirrhotic patient has?
Usually in patients with lymphedema, this is due to deposition of lymph in the subcutaneous and cutaneous tissue. Lymphedema is usually associated with pitting type of edema, and it is associated with specific skin changes like puree orange skin, which is like orange peel appearance of skin, which is due to blockage of the cutaneous lymphatics. Second, we can see that it has a positive stemmer sign. Stemmer sign is in usually edema, we can pinch this skin between first and second toe. In patients with peripheral lymphedema, we cannot pinch the skin between first and second toe. So this is.
You included had all the stemmer sign positive
yes,
and puree orange positive.
Puree orange
Okay.
and-
Thank you.
Thank you, sir.
Doctor, you have to present only 10 slides, so not 20 slides. So skip those which are not important.
Okay, sure, sir. Thank you, sir. Good evening, sir. The title for my paper is Liver Biopsy in Patients with Gallstone Disease and Concomitant Non-Alcoholic Fatty Liver Disease Undergoing Cholecystectomy. This was a study conducted in Department of Surgical Gastroenterology in AIIMS, Patna. The background for this is that non-alcoholic fatty liver disease and non-alcoholic steatohepatitis and gallstone disease have a common cause for have several common risk factors, and the purpose for the study was to find any correlation between the amongst these and to figure out if any diagnostic intervention can be taken up which could help in early therapeutic interventions later on. The aim of the study was to estimate the prevalence of NASH in patients with symptomatic gallstone disease and concomitant fatty liver diagnosed on ultrasound. Our primary objective was to estimate the prevalence of NASH in patients with gallstone disease and concomitant fatty liver disease. Secondary objective was also to identify clinical predictors of NASH in the North Indian population, which can help in timely evaluation and intervention. Our inclusion criteria was patient aged 18 to 17 years who had diagnostic symptomatic gallstone disease and had diagnosed fatty liver on ultrasound. And our exclusion criteria, patients were who were positive for HBV or hepatitis C, history of alcohol intake, diagnosed liver cirrhosis, pregnant patients, or history of any drug intake which affected liver. Sample size was calculated based on Muzon et al., which showed a 10.2% prevalence for NASH, and we calculated a sample size of 131, which was required. 550 patients were analyzed and 150 patients were enrolled into the study. 16 were excluded due to inadequate liver biopsy, and 134 were included. Preoperative analysis was done, and the intervention was intraoperatively. Liver biopsies were taken, core biopsy was taken, and not a wedge biopsy. Wedge biopsy led to taking the biopsy from the fibrous septa of the subcapsular region as well, which could overestimate the stage of the liver disease, the fibrosis. That is why a core biopsy was taken. The biopsy was assessed using hematoxylin and eosin stains, and NFLD activity score and fibrosis score were done according to the clinical research network protocol. In the outcomes, we saw that the demographic profile of our population was that the age was around, the mean age was 43.2. Amongst these, 90 were female of the 134. Mean BMI was 26.53. Most of the patients were in the overweight range, and around 36% were in the obese range. 16% patients had diabetes, 17% had hypertension, 11% had some form of thyroid disease. In the liver biopsy, we found that the patients, 47% of the patients had no NASH, in spite of them being from a demographic predominantly of having metabolic syndrome or overweight or obese patients, and but significantly 15% patients had NASH, and of the 134 patients, 82 patients were also assessed for fibrosis, and in that 23% patients had significant fibrosis, which we took as more than grade 2. In our outcomes, in the significant outcomes, we observed that metabolic syndrome was seen in 86.7% of the cases, but it was not statistically significant. However, in patients of NASH, 86.7% cases were from the metabolic syndrome type. And amongst the various biochemical parameters that we assessed, AST and ALT were two parameters which we saw were elevated preoperatively in patients who were later on found to have NASH, and the results of the values of the CAP also correlated with the presence of NASH. In our outcomes, we figured that in patients with NAFLD, identification of subsets with NASH and liver fibrosis is of utmost importance. There is no marker reliable to indicate presence of NASH. So in our univariate analysis, we found AST and ALT were significant in NASH and non-NASH populations, and only AST was independently associated with NASH in the multivariate analysis. Our study included patients with preoperative diagnosis of NAFLD on ultrasound, and we found a 15.6% prevalence of NASH in such population. The high prevalence of NASH in this population is significant enough to justify liver biopsy during cholecystectomy. early detection and early intervention such as lifestyle modifications and treatment of metabolic comorbidities can help reduce the advanced liver disease burden in the population. So we do, and to add to it, we did not encounter any significant complications associated with liver biopsy in any of our subjects. No bleeding post-operatively. So we concluded that a liver biopsy is advisable in the non-alcoholic fatty liver disease patients with gallstone disease undergoing laparoscopic cholecystectomy, particularly in the subgroup with elevated liver enzymes pre-operatively. Thank you.
What is the complication during the liver biopsy?
So we could have come across patient intraoperatively bleeding, which might not stop, or post-operatively a patient can rebleed because of dislodgement of clot. But since the core biopsy needle was quite fine and it gave us the sufficient sample as well, we did not come across any bleeding or so it was a safe procedure basically.
But general statement like it's advisable, yeah, we should go for it. Just try to avoid these things because a lot of discussion comes. So with this we end our all three oral presenters. So now it's time to know the awardee of this poster and oral presentation. So number 3, third rank is of Dr. Renu Ravuli from Patna. And second is Dr. Rahul. And then obviously first is Dr. Sidali Kodesky.
Just wait.
Presentation I got Dr. Ramesh Chandra sir, Dr. Vimal Kumar, please copy that. Dr. B.M. Dayali not here.
Of the PG students, and they are quite active till the last moment of this wonderful 29th Bihar and Jharkhand chapter of gastroenterology. The third prize goes to Mr. Rishabh. This is third prize goes to Mr. Rishabh. Please come
over the dais, please. Music.
Second prize go to
So we have the third spot winner for our gastro quiz, and we have a medallion for him and a certificate bearing his name, position in this conference. And finally, the best part of it is a coupon, Reliance gift coupon worth rupees 2,000. So many congratulations. Thank you.
second prize go to Ajay. Congratulations, Ajay. You have done very well. Please come forward.
So many congratulations. on this achievement, our 29th annual conference and the gastro quiz second prize winner comes on the stage. May we have a round of applause for him. Many congratulations. So we have a medallion presented by Dr. Vimal Kumar, and associated with that we have a certificate bearing his name and position, the second winner of gastro quiz, and finally a gift coupon worth rupees 3,000 from Reliance. Many congratulations.
And hold your breath.
Hold your breath.
There are many contestants, and only one of them is none but Mr. Aviraj.
This is the first prize. Keep applauding. Thank you. Keep clapping. Many congratulations. You won the first prize. The World Annual Conference prize for quiz. Yes. And the best part of it, from Reliance we are having 5,000 worth rupees of gift coupon. Many congratulations. So it's time, now it's time to present our awards for the best paper, best three papers that will be presented on the dais. May I have the honor to...
Third prize winner, Jainu, Dr. Jainu.
Is he here?
Yes, sir.
Yes. So many congratulations. The third prize you have had that at the third position. You will be getting a medallion, a certificate bearing your name and the position you got in this paper presentation part, and a gift coupon worth rupees 2,000. Many congratulations. So it's just a token, but the importance is so much. You get motivated, you tend to do more and more studies, you tend to face the audience at a big stage. From here now you will face the district audience, after that you will have capital, state chapter, then national chapter. So you will keep on getting these precious experience of participating. You will have points in favor and points against, and you will learn something. So many congratulations. Thank you.
Second prize winner, Dr. Rahul, please come on dais.
Dr. Rahul, maybe have a round of applause for him. Very congratulations.
Again the certificates, medal and Reliance coupon worth 3,000.
Many congratulations again.
And now the first prize winner.
Again hold your breath. The most revered prize in this section of paper category, best paper category is... Can you guess? No guessing please. Only one prize left for grab. So many congratulations again. You will be getting the medallion. Many congratulations. You will get the certificate bearing your name and the position you got. And finally the gift coupon by Reliance worth rupees 5,000 again. Many congratulations.
All the three prizes have gone to names residents.
So IGMS residents have some work to do, I think. Yeah.
Marathon group of deliberation. In that we had some very beautiful experiences. We learned a lot from our national as well as state faculties. Our chairpersons were really very interacting. I thank them all. I also thank all the participants, students, teachers, seniors for being here in large number and getting something out of this conference. And to begin with, we would like to invite our current president, Dr. Ramesh Chandra sir, to bless us with his few words. Chandra sir.
Dear colleagues, institutes of Bihar and Jharkhand chapter of
Indian Society of Gastroenterology, dear friends, my students, it was our pride moment to conclude this exciting midterm 29th Indian Society of Gastroenterology conference. It was a very nice experience. Your participation was excellent. Delegates' participation was excellent. Our speakers have provided us quite good amount of academic feast. We all enjoyed. It was a great effort of Dr. Vijay Shankar, Dr. Ravi Kant, and Dr. Ashish Jha, and Dr. V.M. Dayal, HOD of this gastroenterology GI unit, and your senior residents of the gastroenterology departments, and many others whom I want to remember. So I think we all come forward for next year and next event of Indian Society of Gastroenterology event with all your participations and dedication. We like to increase the momentum of this academic work in future as well. We appreciate the participations who participated in posters and who participated in quiz is really excellent. Thank you all. We all expect your involvement in such activities in future. All blessings to the students and congratulations and thanks to my colleagues. Jai Hind.
May I have the honor to invite Dr. Is he here? He is not. Sir, we would like you to hand over the medallion for the new secretary of our society, Dr. Sanjeev Kumar Jha sir. He is not here. I request Dr. Ravikant to kindly get the medallion from Dr. Chandra sir on Dr. Sanjeev Kumar Jha's behalf. Many congratulations to Sanjeev sir. Now I will also request Chandra sir to kindly hand over the medallion for the new President Dr. Anant Kumar Singh sir, and I will be receiving the medallion on his behalf. And finally, I would like to request all the dignitaries to kindly be seated on the dais. So really it's an emotional moment for me. Being involved in this preparation for last 2.5 or 3 months or so, with the blessings and kind support of all our respected seniors in the society, all our loving and dear colleagues and also our juniors. I would like to thank the residents of this premier institute from the Department of Gastroenterology and few from the Dr. Prateek from the Emergency Medicine Department for supporting me during last a week or so. And I also like to thank the staff and support staffs of the endoscopy department, all the staffs in the security, sanitation. They all were up on their heels to support us and to just conduct the proceedings related to conference in a big way. And also thank our event manager, he is not here, Mr. Yogesh, for a splendid display of all the posters part, electronic media, traveling, accommodation, and all other aspects related to this conference. And also I would like to thank our pharma partners. So they were in a big way behind us, and that they are the very backbones of our this organizational arrangements during this 29th annual conference of ISGBJ. Few of them are in the audience. Mr. Sanjeev, I really cherished your support all around. Mr. Ravi is there, and most importantly, I would like to mention Tushar. You were the backbone for this all. Anytime you had to text him, and within seconds you got the answer and the solution. So many congratulations to you, and I bless that you will have many more such opportunities and many more heights you will achieve in your life. So many congratulations for that only, and a big thank from my heart. You supported me like anything. Other pharma, Cipla, your Alembic, and many others, whoever were with us, we have those posters outside. They supported us. And finally, I would like to thank from the core of my heart the Almighty, and who have blessed us with smooth conduction of this event. And last but not the least to mention is my family, my wife, my son, my daughter, who not only had the heart to tolerate me during this 1.5 months of preparation, but also they had a few very effective inputs that I got related to either the software, designing part, or any other parts of my preparation, and I really feel honored to be a person in that family. So I thank you all. At the end, I bless and I wish that such and such activities and more good quality activity will continue from our side, from our society. New office bearer in the name of President Dr. Anand Singh will carry forward this society's activity. Our respected Dr. Sanjeev Kumar Jha sir from IGMS has got the post of secretaryship, and many other office bearers have taken office yesterday itself. That was decided, and I wish them good luck, and I hope sincerely that from now onwards this conference should be the baseline. We have to go up and up and up. So many congratulations to them and wish them good luck. I thank you all. And I thank you all for joining us.